Are you here? Yes, no. No. I think that come on.
Good luck with that.
I've already done it once. I had to let out the cleaning lady, this is just really annoying. Why does she need to? Like I said to her, don't tell. Don't mention that you're coming, because I don't want this woman to quit way in advance, I'm gonna tell her.
Whatever you tell her, she's gonna do the
I
opposite.
know your sister's coming, but she doesn't, I don't say anything. So when she comes back.
So do most people do 2 or 3 years here? How does that work? Or they do what they like?
Most do too. Some people do. Bobby Kesky was mentioned before. I think it's like it's 4
I guess we'll give everybody a few minutes to assemble here. It looks like people are coming online. Hello, Dr. Ferguson, Brian.
Yeah, we're there. People are coming back in, and then there's some people standing in the hallway, so I'll get them in.
All right, good.
First grand rounds every year.
And if the coffee was warm enough. For
Oh, I made some with the machine, with Jeff's machine. I do want to get a picture with Jeff and everyone. Okay, we should get a check, but at least.
I think when you'll probably get like the.
If someone wants to adjust Dr. Matthews' laptop
Yeah, we'll do a picture, okay.
up so that we see something besides the lights,
All right, let's do it.
a little bit, that works. Thank you.
Let's go ahead.
Okay, let's do it. We are now in the research resident presentations. These are our residents that are away in various laboratories. And all the way from Boston, Massachusetts, Harvard Medical School, we have Dr. Ava Ferguson Bryan from the Center of Surgery and Public Health, Brigham Young and Women's Hospital. Why does it say Brigham Young?
Peter
That's
Ben
the
Brigham.
hometown.
That's what it says there.
Ron Brigham, different.
It's
Different
not Young. Sorry, that's a mistake. Brigham and Women's Hospital, Harvard School of Public Health. Dr. Bryan is going to talk to us about oncologist perspective on omission of sentinel lymph node biopsy in older women with early stage hormonal receptive positive breast cancer. Dr. Ferguson Bryan.
Thanks so much. Can everybody hear me and see my slides properly?
Yeah.
Great. So omission of axillary clearance doesn't affect overall survival for breast cancer in patients who are older than 70 years, have clinical T1N0 disease, and have hormone receptor positive cancers. Adjuvant therapy is increasingly being guided by tumor genomics. And so the Choosing Wisely Foundation recommends against routine sentinel lymph node biopsy in this population. But still, we know about 80% of patients eligible for omission still undergo sentinel lymph node biopsy. And so our objective was to describe surgical, medical, and radiation oncologist perspectives of sentinel lymph node biopsy omission in this patient population. To do this, we conducted a qualitative study interviewing 16 surgical, 6 medical, and 7 radiation oncologists. We did so via semi-structured interviews, the broad domains of which were questions about the impact of guideline factors, social, political, and legal factors, professional interactions, individual health professional factors, and patient factors on sort of perceptions of and practices of sentinel lymph node biopsy omission in this patient population. We used purposive snowball sampling to ensure that we had representation from a range of years in practice, geographic regions, and types of practices. And then we used a modified grounded theory approach to analyze the transcribed interviews. So this is our table 1. You can see that we had a range of years in practice, a mean of 12, but anywhere from 6 months to 30 years. We had oncologists from all 4 quadrants of the country, as well as 3 from Canada, a wide variety of practice settings from academic, community, and hybrid, and then a real range of the percent of their practices constituted by breast from 10 to 100%. So this diagram highlights the domains, subdomains, and emergent themes that we found from our analysis. So starting from the sort of the central box and working out in terms of clinical factors, really disease factors such as tumor characteristics, likelihood of a positive node, and then adjunct imaging technologies like ultrasound or MRI results, patient factors, chronologic age, really importantly, physiologic age, and then patient preference factored into practices and perceptions of the mission, working outward towards that next sort of concentric rectangle multidisciplinary factors. We have multidisciplinary considerations such as interdisciplinary attitude concerns, tumor board and pre-op discussions, and then downstream effects such as radiation oncology and medical oncology workarounds after omission of surgical evaluation of the axilla. Specific radiation oncology workarounds such as high tangents or sort of omission of partial breast irradiation. And then finally, in that largest box, external factors, we found institutional, institutional and cultural factors such as malpractice concerns, but really a lack of specific institutional pressure. In terms of guideline factors, we found disparate views on and knowledge of evidence supporting the choosing wisely recommendation, and then institution-specific guidelines at certain institutions. So just looking at some of the representative quotations for these subdomains. So in terms of disease factors, we can see, for instance, the surgeon quoted in the sort of the top quote here: size of the primary tumor is also important. I mean, if it's a 4mm tumor, it's unlikely to yield a positive sentinel node. And then the medical oncologist below, I go by pathology features. For example, for patients with extensive LBI, a relatively low ER and negative PR, I certainly would consider those patients, whether they would benefit from chemotherapy. And in that situation, the sentinel lymph node biopsy would be helpful to guide adjuvant therapy. In terms of patient factors, I would see the surgeon in sort of the first quote position. A lot of it really does for me have to do with eyeballing patients. I have patients who are in a nursing home setting and they come to me in a wheelchair or something and they're brought by someone. And it's very easy to look at these patients and say, you know, we really don't need sentinel nodes in these patients. The importance of physiologic age over chronologic age was highlighted by many of our interviewees. And then the medical oncologist below. And then we think, is she going to be taking endocrine therapy? Do we know her bone health? That'll give us just a little bit more reassurance that she doesn't need more local therapy if we're going to be able to keep her on an endocrine therapy for sure. So participation in endocrine therapy was really sort of a guiding sort of pre-op consideration for many oncologists that we spoke to. In terms of multidisciplinary considerations, this first radiation oncologist quote is long, but sort of comes down to a perceived conflict between their desire to have surgical evaluation of the axilla so that they don't go about making their treatment decisions quote unquote blindly. And then on the other end of the spectrum, the surgeon quoted below, who says, we certainly review all of our cases through our multidisciplinary conference that we have on a weekly basis. And so it's more or less a decision that myself, as the only breast surgeon in the community, and the oncologist sit down and talk about. In terms of downstream effects on adjuvant decision-making, the medical oncologist in the position of the first quote says, in the absence of the sentinel node, if we were considering chemotherapy, we would send to the oncotype. And so I would base my recommendations on the oncotype and then on their life expectancy. The radiation oncologist quoted in that second position said, in the absence of a sentinel lymph node biopsy, I would probably get an ultrasound. I might even get a CT. And then the surgeon quoted third says, I get the sense that radiation is quite comfortable with emission of sentinel lymph node biopsy as well. But I get the sense that medical oncology has more hesitations in this regard. And really the impact either as sort of explained by the medical or radiation oncologists, or the perception of on the part of surgeons of the impact that omission of sentinel lymph node biopsy would have on medical and radiation oncologists was a really important theme that that many of the respondents discussed. So finally, looking at the subdomains in sort of that largest box of external factors, many respondents said that malpractice or fear of malpractice drove sentinel lymph node biopsy even in patients who otherwise might be candidates for omission. But we really didn't hear from any respondents that specific financial pressures or RVU pressures were guiding this particular decision making. And finally, guideline factors. So there was a lot of confusion about exactly what was the data that went into the creation of this choosing wisely recommendation. A lot of respondents who thought that it was put together using retrospective data, a lack of RCTs. Some surgeons, such as surgeon number two quoted in that first position, really didn't think that the lack of data mattered that much, but we had multiple respondents who thought that the lack of data really sort of impacted their willingness to omit sentinel lymph node biopsy in eligible patients. So in conclusion, there are multidisciplinary ramifications for sentinel lymph node biopsy omission that might not have been fully sort of teased out in the choosing wisely recommendation as it stands now, and potential downstream effects on treatment decision-making for adjuvant therapy. Possible interventions might help decrease sentinel lymph node biopsy rates in this patient population in a meaningful and appropriate way, educating breast oncologists on the data used to construct the choosing wisely recommendation, and then facilitating preoperative multidisciplinary conversations around sentinel lymph node biopsy omission in this patient population. And that is it. Thank you so much for your attention and for the chance to present. So nice to see everybody.
Thank you so much, Dr. Ferguson Bryan. Are there any questions from the audience? Looks like somebody just got thrown the microphone. It's Dr. Jaskowiak.
Dr. Jaskowiak and Ferengi are having
We're having a reunion.
I love that.
Having a UCSF reunion.
Ava, that was awesome. Thank you so much. So good to see you. When are you coming
So good
back?
to see you too. Hopefully in July, but you'll have to ask the thoracic search committee.
Oh, don't hold that over our heads.
This is like a cameo. This is a cameo
Wink,
appearance.
wink,
You know?
wink, wink, hint, hint, nudge, nudge.
Say no more. All right, so I guess one thing I didn't see in your presentation, which was amazing, is sometimes the patients, like maybe I missed that, but sometimes the patients really will say something. I mean, all the time, there are patients who say, you are not getting, I have to know my sentinel node. I will look at the ceiling, lay awake at night at 3 a.m. wondering if there was disease in my nodes. And so I just wondered if you looked at that, or if that was part of your conversation.
Yeah, definitely. So in that sort of the clinical factors domain, patient preference and patient demand definitely came up, multiple times from all three of the disciplines that we talked to. In sort of the interest of time, I didn't highlight those particular quotes in the sort of exposition of themes, but definitely that was that was a common theme among a lot of the respondents that we interviewed.
Thank you. That was a great presentation. I sort of have one comment to mirror Nora's, which is that, I find, I do thyroid cancer where the nodes are definitely pretty much shown not to be clinically important in terms of survival or anything like that. And yet when patients have had breast cancer, they're asking me, oh, make sure you take out my lymph nodes, just like they did for the breast cancer. I gotta know.
Yeah.
So we have that discussion even in a different disease by the breast cancer patients. I was just wondering what your actionable items are next. So you did all these structured interviews. What are the actionable items you're gonna, then learn, give out to everyone else to be able to change patterns of behavior, perhaps?
Yeah, so I think that especially when we are talking about sort of the perceptions of this recommendation among oncologists of all three stripes. And again, there was a lot of confusion about exactly sort of the studies that that went into the creation of the guidelines. I believe that they were sort of retrospective analyses, and there were actually multiple RCTs that that sort of fueled this specific recommendation. The epistemic slide is that they all evaluated whether or not axillary clearance had a survival benefit in this particular patient population, and not necessarily sentinel lymph node biopsy. And so I think where we saw a lot of the tension was that, even if we have RCT level evidence that says to surgeons that, you might as well omit the sentinel lymph node biopsy because, there's what you would do with that information isn't, it doesn't have a survival benefit for your patients. It still has implications or, perceived implications for the decisions that the medical oncologists and the radiation oncologists make in terms of, their adjuvant therapies. And so, I think a better campaign on choosing wisely's part around the data that went into these recommendations, I think can at least, fuel a more sort of data grounded and informed conversation among these multidisciplinary partners about whether or not for a particular patient, omission of sentinel lymph node biopsy is really going to change downstream adjuvant management. So I think that's probably the most immediate actionable recommendation.
There's a question in the Q&A from Dr. Hansen, who's in plastic surgery, who I think arrived after you left for your for research. But she asks, would structured interviews with a patient advisory committee be included?
Yeah, I mean, to Dr. Jaskowiak's first question, right? The sort of the patient experience of omission of sentinel lymph node biopsy and sort of what that anxiety does to their experience of treatment. And, I think that's a great idea and something that I will take back to my research mentors here, because I think that's a great next step.
Wonderful. Thank you very much. So nice to see you. You look
Nice
great.
to see you too. Thank you.
Say hi
Nice
to your
to see
husband.
everybody. I will.
Baby.
Yes.
Where's the baby?
Right.
Can't see.
The baby is asleep like an angel in the next room. I was crossing my fingers that nap time was going to extend over the course of my presentation, and it did. So,
Excellent.
hallelujah.
Nice job.
For
Nice
small
job.
miracles.
Great. All right. We're going to go a little bit out of order. We were lucky enough to have Dr. Paris Gutierrez, who was our transplant surgeon, who was faculty member, come back out of the operating room. She got pulled into the operating room. So she couldn't do her 12:45 presentation, but she's going to do it now. Dr. Paris Gutierrez is going to talk to us about a positive B2 microglobulin trend after kidney transplant identifies worse outcomes in patients with delayed graft function.
We have a presentation.
Hi.
Go ahead.
Thank you. I'm so sorry. I just disrupted the schedule. I'm so happy that I'm able to present. Thank you for inviting me. So are you seeing the right screen there?
Yes. Yeah.
Okay, sounds good. Okay, so delayed graft function is a very common complication after kidney transplant. It happens usually 20% of the cases, and in those kidneys that are that use donors after circulatory death is up to 40 to 50%. There are multiple definitions for delayed graft function, and the most accepted one is the need for dialysis the first 7 days after transplant. And it is associated with worse short and long-term outcomes after kidney transplant, including rejection and death. The serum beta-2 microglobulin is a low molecular protein that filters freely by the glomerulus. We can measure GFR based on beta-2 microglobulin. It strongly correlates with cystatin C and creatinine. It has the advantage of measuring residual kidney function in patients on dialysis. And that's very important for us because following the creatinine when the patient is on dialysis is not so accurate. And that's the case of the patients with delayed graft function. You may remember the beta-2 microglobulin as part of the MHC class 1 molecule, but the one I'm gonna be talking about is the soluble beta-2 microglobulin that it is circulating. In kidney transplant patients, beta-2 microglobulin at the time of discharge, it is associated with overall mortality and graft failure. And in stable patients, if we measure the GFR based on beta-2 microglobulin, and they did it the first 6 months after transplant, if it's elevated, it's associated with cardiovascular events and mortality. So that's the information we have about beta-2 microglobulin and kidney. There is not much information about what is the role of beta-2 in the presence of delayed graft function. And it's important to know that very few centers use beta-2 microglobulin. We have been checking it for more than 10 years, and the rationale to follow was that it helps to differentiate between delayed graft function and early rejection. So our objective was to determine the beta-2 microglobulin trend immediately after transplant and to evaluate the role of the beta-2 microglobulin trend in patients with delayed graft function after transplant. This is a retrospective single center study. We include all the deceased donor kidney transplant recipients, excluding obviously pediatric and multi-organ transplants. And we did a revision from 2013 to 2020. We did a total of 304 patients. The beta-2 microglobulin and the creatinine trend was calculated as a linear regression of the determination that we have in days 1 to 5. And these are a couple of examples. This is a patient that didn't have delayed graft function. We usually discharge patients day 4 or 5. So we have the data only for the first 5 days usually, and we don't check it later. So if we do regression, then we can have like how much in average is gonna be decreasing or increasing. So that give me the number that I'm gonna be calling trend. So it's like, and I think that can be related to how we usually clinically see if it's going up or down and how much. This is a patient with delayed graft function. This patient had dialysis day 1, 2, and 5. And you can see how creatinine can decrease significantly after dialysis and maybe is not so accurate. We have a lot of delayed graft function. Up to 40% of our kidneys have delayed graft function. The median duration, it's only 7 days. So it's not so bad. They usually need a couple of sessions and then that's all. And in our series, we had like 3 primary non-function. That means that the kidney didn't work. The population was similar between the patients that had delayed graft function and those who didn't. Except for waiting time that was more in patients with delayed graft function. And as expected, those transplants from donors from circulatory death had more DGF, and that's very well known. Overall, there is a significant decrease of beta-2 microglobulin immediately after transplant, and then slowly the trends come down. And there is a strong correlation between the beta-2 and the creatinine trend. And this is all the patients. Both beta-2 microglobulin and creatinine are associated with the presence of delayed graft function, and that was expected. If you have more beta-2 microglobulin trend, then those patients usually have DGF, and if patients that didn't have DGF have less trend, and the same happens for the creatinine. So this was expected to have a correlation for both with delayed graft function. We didn't find any association between the beta-2 microglobulin trend and death or rejection. But when we look into how many days the delayed graft function had, if we divided between less than 7 days or more than 7 days, the beta-2 microglobulin trend is associated with delayed graft function that lasts more than 7 days, and that didn't happen with creatinine. Then I wanted to see what happened with those patients that have both beta-2 microglobulin and creatinine trend positive, because I wanted to see if these patients were worse to those that had delayed graft function but didn't have positive trends. And I really didn't find any association with long delayed graft function, rejection, or death. In summary, positive beta-2 microglobulin trend is associated with the presence of delayed graft function, and that is similar to creatinine, and that was completely expected. The beta-2 microglobulin trend was significantly associated with the duration of delayed graft function, and that is unlike creatinine, and that has never been reported before. We observed no association between beta-2 microglobulin trend and rejection. So why is this important? Well, beta-2 microglobulin trend can help to make clinical decisions towards renal allograft recovery, such as changing immunosuppressive treatment, trying to avoid CNI toxicity or other nephrotoxic drugs, better blood pressure control, maybe improve or do more rejection surveillance, and also create better logistics for discharge. And that's all. Thank you for your attention. I'm happy to answer any questions.
Thank you very much. Nice presentation, very lucid, very understandable, and exciting from the standpoint of its clinical utility. Do you have any idea of how you might do this prospectively so that you could actually track these and prove in a sort of a Bayesian analysis what the positive predictive value and negative predictive value of this test is?
So is something that we were using and we are using already. Is more than when I look what is the evidence of what is the value of the beta-2 microglobulin trend. I didn't find much information. So I think we can prospectively gather more cases, and then and then we can see if we do actually change our clinical decision based on that. But it's something that we are already following. Yeah.
Excellent. Are there any other questions, Dr. Matthews?
I was going to comment on that, Dr. Perez. Angie, that was great. It would be great to take advantage of this, sort of like we were talking about with one of the earlier papers. The early warning sign that you come up with is really only valuable if there's an intervention. And if you can protocolize that intervention and show that those curves are going to, deviate, and that you'll enhance or improve the ultimate graft function or change the time to recovery of graft function, that would be a real practice changing thing and very high impact. So are you getting that going now in a protocolized way?
So we have not, but definitely I think there are several interventions that can be directed to try to minimize the impact of delayed graft function. And I think it's something that we can do. Like, okay, if the trend is positive, we're gonna do like this. If it's negative, we will do this. I think definitely we have not protocolized before, but it's something that can be done, and I think it's important to just go into that direction.
You've got such a high number of delayed graft functions that you should be able to get an outcome, some immeasurable impact.
Excellent. Thank you very much. I'm sorry, Dr.
No, I was
Prandi.
going to say that was a great talk, and I sort of was going to follow up on Jeff's question in the sense that now that you know the signal is valid on the length, maybe you could just concentrate on the ones, the deceased donor, the death after cardiac arrest pool. So you just use that group as your action item group, since they have such a high rate. I forget, it was like 46% or something, that are, then maybe you just can enrich your group with just that group.
Yeah, I think that is a very good point in terms of the delayed graft function of patients from donors that are from circulatory death is different than the delayed graft function from a brain dead. So I think that gives room to see maybe how is it different, and if it can be improved or not, or if it's bad prognostic or not.
Excellent.
Great, thank you.
Thank you very much. Great job. Beautifully presented. We're going to jump back now to our research resident presentations. And there are 3 of them left, so you each have 10 minutes for your presentation. So is Seth Sankari on board here to present?
He is.
I'll do it.
He is. Okay, Seth.
Just for you.
Simulation of thoracic aortic stent deployment from Dr. Koitkin's lab. No, that's not right. That's not right. He doesn't do aortic stent deployment. That sounds like somebody in vascular. Go ahead, Seth.
Thanks. So thank you all for allowing me to discuss my research. Today I'm going to provide a brief overview of some of the computational simulations of stent deployment that we're doing in the Posibelchik lab. So in the context of our lab, when we discuss a computational simulation, what we're talking about is a specific type of modeling called finite element analysis. It's a method that's widely used in engineering, and it uses partial differential equations to solve how different materials react under a given load. This can be used for simple structures, such as a piston showing mapping out the strain, or complex systems, such as a car decelerating into a wall. Within the aorta, in our lab, to generate the structural information needed, we use CTA imaging to generate a patient-specific 3D representation of the aorta. Here, that line represents the aortic center line. The red is the true lumen. The orange is the false lumen. And we can get this structure that we can then perform different things on. First, we start by smoothing it to take out any artifact. And then we break it up into hundreds of thousands of individual elements in a process called meshing. These act as a lattice on which we can apply different loads and see different results. For example, this is a simulation of an aorta that is pressurized to 20 millimeters of mercury and a growth algorithm is applied. And we model how the aorta shape changes over time. Specific to my project, working with aortic stent deployment, I had a few challenges to get the optimal stent graft design. First, I started by taking CT images of a Medtronic Valiant, which is a T-bar stent, and then recreating the model similar to how I did it with the aorta. The problem is the metal struts and the graft material don't oppose well. So next we tried using a CAD model of an endospan, another thoracic stent, which unfortunately still wouldn't run in our model. So our most recent iteration is an in silico cylinder that essentially is made in the computer, has the same material properties as PTFE, which is the graft that's used in T-bars. So next, for stent deployment, in order to get this in the proper place, we had to use the center line of the aorta. We then created a customized code in MATLAB to bend the stent into the appropriate orientation. And then when you put it into a finite element solver like Abacus, you get these 3 things. So this first stage is crimping. You take a fully deployed stent, you have to shrink it to the size that it would be deployed in. Next, after it's shrunk, you have to bend it into place. So this is based on the patient's specific anatomy, where it would deploy. And then lastly, you have to inflate it, balloon it. So we apply an internal pressure on the stent, which allows it to balloon up to full size. So what do we do with all this information? So we use something called CFD, Computational Fluid Dynamics. And it's an analytical format that assumes the aortic wall and the stent are rigid bodies, and then it can map out fluid flow. Essentially, you're looking at 3 cardiac cycles, and you're mapping out the flow of blood. And here you can see that blood is flowing outside the stent, which in vascular surgery is an endo leak and considered an important complication. And so if you see here, this is the patient, the same patient post their T-bar. And what you're seeing here, this white endo leak, is something that you're seeing in these blue streaks that are folding in the model. And you can see that in multiple orientations. So moving forward, this project is interesting, but I still need to improve the stent graft design. I went over some of the challenges. I want to continue to improve the realism of aortic modeling. What you saw was the whole aortic shell, but that can be divided into the true lumen, the false lumen, and get that dissection flap. And then this tool allows you to study the factors that influence seal zone stability, both anatomic and physiologic. So how curved the aorta is something you can modify, and how that impacts the ability of the stent to have a good seal, as well as things like blood pressure control, heart rate control can all be modeled. We hope to validate these in silico findings with patient-specific outcomes. So like you saw in our model, we can look at patients' CT post-intervention and say, does it align with our model? And then one avenue our lab seeks to do is to use 3D printing of patient aortas and sort of validate this in silico model with experimental values and sort of build up that avenue of the lab. So thank you for all the department, the mentors, and happy to take any questions.
Great job. Are there any questions?
There's nothing in the chat or the
Seth.
Q&A.
Dr. Taraga's got one.
Yeah, Seth and Luca, that was that's fantastic work, and of course, great job. Can you speak a little bit about the fact that you're using dynamic or maybe even static CT images to kind of assess sort of the elasticity and properties of the vessel wall? And why not use things like elastography or intravascular ultrasounds that would give you more data to inform your finite element analysis?
Good comments. So the reason we use the CT imaging is it gives us the best 3D representation of the aorta. It's going to give us the best picture. And then what that program, that XFlow, can do is implement real physiologic changes in flow. And so you can change the loads on the aortic wall. We're in the process of being able to couple both those fluid dynamic changes and mechanical changes in the aortic wall property. So the short answer is it's harder to do, but you can do it to model using finite element analysis. CT gives us a little bit of a better picture, and a lot of our earlier work was dealing specifically with the geometry and how the geometry of the aorta changes and how that affects patient outcomes. So that's why we started with CT. It's also more readily available.
So I have kind of a dumb question.
Yeah.
So with the last slide that you showed,
Mhm.
I think I maybe got my own answer. Yeah, the one with the flow.
Oh, yes.
So is the idea that you are developing this model so that you can then predict, you can put that stent on the left in 10 different places and predict which one is the one that won't give you the leak and all the other things? Is that kind of the purpose of the simulation exercise?
Yeah, that's
Okay.
that's one thing.
I just wanted, okay, good. At least I got one thing. I feel good now.
Great.
Dr. Hibbenel?
So when you see that when you simulate the stent deployment, every stent has different character and when you deploy, and then that simulation is a bit different from usual aorta simulation. So that simulation also can affect how you design patient-specific designing. So how do you decide when you do the simulation for how the stent is go there and how the stent will?
Sure. So in order to try and match reality as best as we can, we took the patient's pre-op CT scan and used that as our baseline geometry. But then we used the center line for the immediate post-op after the stent had deployed. And I was only looking at this, basically the whole area where the stent was. And so I can apply a displacement to put the stent essentially in the position that it happened when they actually had their T-bar. And then you can look and see how the flow happens afterwards. There are still challenges with stent deployment, that it doesn't deploy in the same way that a stent, when you're actually doing it in vivo, does. And that's something I'm hoping to address.
Great job. Thank you, Seth. It's fascinating work, and I'm sure the best is yet to come. Okay, let's have our next presenter from our residence. Now, this one is from Koikken's lab for sure. Dr. Jelani Williams, the role of all-trans retinoic acid in increasing the radiosensitivity of pancreatic neuroendocrine tumors. Jelani?
Ryan, should I pull it up or are you?
No, go ahead. You pull up. Hit share
You
screen.
should be able
You
to
should
share
be
it.
active.
Is Jelani supposed to do it or are you doing it, Ryan?
Got it.
We have
Jelani's got it.
That doesn't work, but perfect.
Yeah, great.
All right, can everybody see that and hear me okay?
Yes.
All right, thank you guys for the opportunity to present this work. Just a little background, pancreatic neuroendocrine tumors comprise up to 10% of all pancreatic malignancies. They derive from the endocrine cells of the pancreas as opposed to the ductal cells that we see in the more common adenocarcinoma. And thus, these endocrine cells oftentimes can secrete certain tumors, certain hormones. They express somatostatin receptors 2 and 5 mainly on their cell surface. And that's important clinically when prescribing somatostatin analogs like octreotide and other drugs like PRRT, which I'll talk about next. PRRT, or peptide receptor radionuclide therapy, is an effective treatment for all neuroendocrine tumors. It's particularly effective for the pancreatic subtype, for PNETs, as shown here. The way PRRT works is by binding to the somatostatin receptors we talked about and delivering toxic amounts of radiation to the cells. PRRT is imperfect, however, and there's several ways we try to improve upon its efficacy. You can improve the perfusion of the drug to the tissues. You can try to increase the amount of somatostatin receptors, which I talked about last year using external beam radiation. You can use drug therapies that target similar pathways to PRRT, like PARP inhibition. But the focus of the talk today will be using all-trans retinoic acid, or ATRA, to make cells more sensitive. So our lab has shown that MEN1 is important for transcribing homologous recombination genes. And that loss of MEN1 that you see in many PNETs actually leads to impaired DNA repair, particularly double-stranded breaks after radiation damage. And also makes them more susceptible to PARP inhibition. PARP inhibitors, they target a different arm of DNA repair, and thus you have a double hit on the DNA repair mechanism. So here, though, we propose that ATRA, by inhibiting PIN1's function, can lead to the sensitization of cells similar to loss of MEN1. And that's because PIN1, as you can see here, is important for activating estrogen receptor and BRCA1, which are both involved in DNA repair. So basically, we're suggesting that using ATRA to turn MEN1 proficient wild-type cells, like lung and small bowel neuroendocrine tumors, to make them more radiosensitive, more sensitive to PRRT, and more prone to PARP inhibition. So looking here, we see that ATRA indeed radiosensitizes PNETs. In our lab, one of many cells we use is this QGP1 cell line, which is a human PNET cell line. And you can see the addition of ATRA plus radiation leads to decreased cell growth or increased cell death compared to just radiation alone. ATRA also affects homologous recombination, as we saw in the schematic, but also looking at the PCR data, you see with estrogen receptor and PIN1, there's a decreased expression of those genes when you combine ATRA with irradiation. Looking at BRCA1 and BRCA2, you see a similar pattern where there's an increase in these two genes after radiation. That's expected because BRCA1 and BRCA2 are involved in DNA repair. So after radiation, you see those levels increase. But then that increase is blunted, it's decreased when you co-treat ATRA with irradiation. And this is important because it's showing that we can basically decrease the expression of these genes that are important for DNA repair, so that cells can't repair DNA after damage. Looking at Western blot and protein data, we see with gamma H2AX, which is a marker of DNA damage, that it is qualitatively increased in our QGP1 cell lines, the PNET cell lines, when you co-treat ATRA and radiation. You see an increase in gamma H2AX. So to conclude, ATRA radiosensitizes QGP1 cells, as we saw from our first graphic. ATRA increases DNA damage, as evidenced by H2AX levels. ATRA affects transcription of estrogen receptor 1, PIN1, and homologous recombination repair genes, as well as BRCA1 and BRCA2, all of which are involved in DNA repair damage. And these findings altogether suggest that ATRA should be further studied to radiosensitize PNETs and other neuroendocrine subtypes like lung and small bowel that again are MEN1 proficient cells. So our next steps will be to co-administer ATRA with PARP inhibition to assess for synthetic lethality. Ultimately, though, we want to expand these experiments to include those other neuroendocrine tumor cell lines and to combine ATRA and PRRT in animal models. I want to thank the Koiken Lab and the department for allowing me to do this work, and I'll stop there for questions.
Thank you very much. Beautifully presented, Jelani. Are there any questions?
Jelani, that was great. I just wanted to ask, I'm just trying to understand, what are the barriers to getting that into a human model? What do you anticipate into, sort of translation to the clinic to get it out of the in vitro situation?
Yeah, so we want to make sure we prove this concept in cells, which we're shown here, and then we want to translate that to mice. We have a nice mice model where we have subdermal injection of these tumor cells, and we treat them with PARP inhibition. We actually just got approved to give the mice PRRT, which is a hurdle in and of itself. So once we prove that in the mice, then I think it'll be a relatively easy transition to humans, because we give this to our patients all the time, PRRT.
Right.
How are you going to protect against tachyphylaxis? As I recall from receptor theory, the more agonist you add, the cell will protect itself by downregulating affinity or transduction of that receptor. And it seems to me that since you're using such a ubiquitous agonist that cells see all the time, you're going to have that problem across different cell lines and mutations.
That's an interesting point you bring up. I think so far we haven't seen that, and I think it's important for us to look at that too. How much, what dose, for example, do you get? Sort of what you're talking about. We haven't seen that yet. Perhaps at higher levels of the drug and higher levels of radiation, we might see that, but so far we have not. But that's, I think, is an important consideration to keep in the back of our minds moving forward, for sure.
Wonderful. Okay, let's move on to our last presentation in this group, which is by Dr. Hunter Whitmer, Surgical Teamwork. Are you happy or not? Keeping in mind that happiness is frowned upon here at the University of Chicago. This is from the Turaga Lab, probably the same at Harvard, I'm assuming, Dr. Perengi.
That's too funny.
All right. Thank you, everyone. Good afternoon. So the last few years have certainly put a spotlight on well-being in healthcare as we see unprecedented levels of provider burnout. And although substantial stress is related to the nature of the work itself, effective and rewarding collaboration between providers may offset these negative effects. The literature, however, rarely addresses how members of surgical teams perceive the quality of their collaborations. And this is related to the fact that merely collecting the relevant data is very difficult. And so we set out to study physician and nurse satisfaction, specifically with regards to teamwork in the operating room. So our first goal was to identify variables associated with superior surgical teamwork. We also hypothesized that more effective teams would perform better, leading to superior results. So we sought to relate these data on team satisfaction to meaningful patient and operational outcomes. To do this, we installed these happy or not devices in each of our main ORs. Which I feel like I owe an explanation to everyone who's seen these buttons in the ORs now. And so we analyzed responses to a validated prompt, which was collected over a 24-week period, and cross-referenced responses with OR log and clinical data. So these response rates, varied significantly from service to service, ranging from about 8.7% in trauma to 44.9% in general surgery. And this led to an overall response rate covering about a third of all eligible cases. We then used logistic regression modeling to calculate the odds ratios that any team member would report being very satisfied with the teamwork in a case. Our analysis included proxies for nursing familiarity in the service line, case characteristics, and attending surgeon characteristics as shown. In our univariate analysis, teams generally appeared to find that metrics of nurse familiarity and timing variables were important, but not characteristics of the attending surgeon. And please note here that procedure time or standardized procedure time is not raw procedure duration. It's actually case duration as a z-score for the given surgeon. So this means that cases running longer than expected, not just longer in absolute terms, are associated with worse ratings of teamwork quality, and hence the odds ratio less than 1 here. In multivariate modeling, only scrub service experience and nighttime cases were independently predictive of satisfaction responses, but in opposite directions. So in other words, for a given case, the more often your scrub nurse worked in that service line, the higher the teamwork rating or the higher your likelihood of having the highest possible rating. And conversely, if a case started after 3 p.m., the team was 26% less likely on average to be very satisfied with their performance. And I want to point out that although we see standardized procedure time here is no longer strictly significant, it does appear borderline significant. So finally, we looked at supply utilization and patient lengths of stay following these procedures. And cases with the highest teamwork ratings were associated with a 15% shorter length of stay on average, but also a greater cost of supplies used during the case. We did not observe any association between satisfaction responses and the wastage or odds of wasting surgical supplies. And this is controlling for a number of the factors associated with variation in these outcomes. So to summarize here, we're introducing a new approach to studying collaboration between providers in the OR and suggest some potential drivers of superior teamwork. Our group sought to illustrate the feasibility of this approach and highlight the salience of team satisfaction in both clinical and administrative contexts, because we believe that these data are actionable and justify focusing on data-driven approaches to OR staffing, both to improve the subjective workplace experience and the quality of patient care. So with that, thank you. I'd like to acknowledge a lot of hard work put in by our research team. And I'm happy to answer any questions there are any.
Thank you very much, Hunter. It was a great presentation. Are there any questions? Dr. Paris Gutierrez, you raised your hand. Can you come online or do you want me to read it?
I will allow her to talk. You can
There you
unmute
go.
anytime.
Hi, yeah, very interesting project and nice presentation. I saw them, but nobody told me, oh, you have to say that. And then at some point I say, oh, I'm always happy. I'm just gonna be putting happy faces and then the patients are gonna do terrible. And I didn't know if that was gonna be analyzed. But I think it's very interesting. I think we will have like maybe more response. But I just wanted to know in terms of you say okay, better outcomes when the team is happier. But did you control for time, the duration of the case? Because that will be different outcomes in cases that are maybe more difficult and also supply costs as well. And maybe everybody is happier if the case is not super long or super difficult.
Yes, I think you hit on a number of things. So I think how this is presented is actually deceptively simple. There is a lot to unpack here. And I think to answer some of your first questions, we did adjust, so we did control for things like the service line, the raw procedure duration, not just the standardized time, and a litany of other factors that we found were, associated with your odds of supply utilization or waste. So yes, this is controlling for many of those things. I think getting back to the mention of standardized time, one of the reasons why we felt like it was important to treat time in this manner is because obviously operations naturally vary in length. And what we're not interested in looking at is whether people are happier with how their team works for long cases versus short cases. We're interested in how a relative change in time affects whether you think your team performed well. So actually, I do have some interesting points on that because we broke these out by role. And what you start to see is that even though the standardized procedure time wasn't strictly significant, all of its significance is being driven by responses from the surgeon specifically. So not only is this kind of marginally significant, but it's also very much dependent on who's answering. And I mean, anecdotally, this makes sense, right? If you are the only non-shift based team member there, you're going to care if it's an evening case, if it's running longer than it was expected to, and so on. So there, we are, you know, there's a lot of considerations here. And I think the last thing that you mentioned is, what are people actually responding to when they read this prompt? You know, because it's compared to the typical case, how satisfied are you with the teamwork of this case? Are you thinking about the subjective flow of how the case went? Are you thinking about the timeliness with which you received or did not receive the particular instrument or device that you wanted? Are you thinking about the expected clinical outcome for the patient? That, you know, there's a lot of different things that can play in. We know from a lot of the behavioral science research that context matters a lot in how people you know, interpret their subjective perceptions. So there are many layers to this, but we're trying to account for that as best we can.
I think this is a fantastic study. I wish I had buttons to push in the OR. Honestly, I mean, this is so valuable, right? Because it shows in this day and age where there's so many travelers, if they can really concentrate on the scrub, it makes everybody more satisfied, right? Rather than assigning a traveler scrub to the case that has zero experience. I mean, this is really fantastic. In fact, I want you to send me the slides so I can take them to our OR in all seriousness. I mean, it's really, really useful information. And I think, I mean, which surgeon wouldn't be happy? You get an experienced scrub who opens all the expensive things you want, and then you're happy. I mean, that's kind of your conclusion. I'm very happy with that.
Yeah, I think to that point, a substantial part of this, I think, I don't have much to back it up, but I think that what people are conditioning their response on is that timeliness aspect of having supplies ready. And therefore, the more supplies that are opened and available, whether they are used or not, is probably, you know, this preceding step to whether they're available when you want them. And so that's my at least explanation for why we see the supply. And I think there's issues with how waste is recorded. You're missing a lot of the small items. It's inconsistent whether items are recorded officially as wasted or not. So, you know, there's some difficulties inherent to those data as well.
Thank you. We have one question. Paige, do you want to read that question?
Yeah, and we actually got another one in there at the same time. So a twofer. First, did you evaluate the correlation between low response rates and overall nursing team experience? Perhaps response rates are directly proportional to the consistency and or experience of the nursing teams.
So we did not look at the combined experience of the team and whether or not they responded, you know, at all. What we did look at was correlations between the roles. You know, there are well-described instances in literature, or observations, I should say, where physicians and nurses have significant differences in how they perceive the quality of collaborations in the OR and in ICU settings, outpatient settings, and so on. And we do see that. We also see a kind of interesting stepwise correlation where so nurses obviously have the highest correlation. They appear to be observing the same interactions or whatever it is when they enter their responses. Next comes the surgeon and the scrub nurse, presumably because they are the closest in proximity and because of their how they work together, that being, you know, very immediate, how both will perceive teamwork. And then so they have the second highest correlation. And then following that is correlations with anesthesia and circulator, which are still, you know, moderate when it comes to, you know, survey response data. So they are moderately well correlated, but not to the degree that either the nurses are with each other or that the surgeons are with the scrub nurses or technicians.
Thank you. And then the second question that we got in the Q&A is, this person didn't hear the limitations, might have missed it, but how do we control for the fact that I was just having a bad day and just not happy, and then broadcasting it on my experience with the team? Maybe many may be unable to generate feelings with their experience in the OR.
Yeah, I think there are many limitations. to this.
Damn it.
First of all, there's all the problems attendant to survey data, right? You're not directly seeing who's pushing the button. You don't know what's going on in someone's head when they do. We have to make some inferences as to who actually hit the button based off of who the primary scrub and circulator was for the case, and so on and so forth. So there are many things, and that's one of the reasons why I don't make too aggressive a statement regarding the conclusions for patient outcomes or wastage. I think this is more exploratory. It raises some really interesting questions. And I think the most important aspect of this is trying to put real data to things that we anecdotally believe are true, whether they are or not.
Thank you, Hunter.
We got one more question. One more question.
Oh, okay, go ahead. Go ahead, Jeff.
Hi, Dr. Alberti. Hi, Hunter. This is Annie. So I would assume that part of the reason for doing this research is to try to correlate or put together teams in the OR that would best suit either team happiness or patient outcomes, whatever you're looking at. I'm kind of interested in how you would account for variability then in the future, because there's work out there on anti-fragility and robustness of teams, and how if you don't actually build in some variability into this, then when the system has a glitch, it totally falls apart instead of coming out stronger. So I'm wondering if you were to use this, or as you're analyzing, if you're looking at different ways in which you can build in enough variation that there's enough people to fill in if someone were to be missing, or you didn't have the team that you ideally want for the day.
Yeah, so the question is primarily about the concern of hyper-specialization, right? And if you don't have sufficient conditions to meet needs and yet have a hyper-specialized team, is there going to be crossover functionality there, right? And the big headache with this kind of analyzing operational OR data is heterogeneity. But the thing that prevents, I think, what you're talking about, where if you're trying to assemble teams and the conditions aren't right, suddenly you're putting people with no experience into one room where the stakes are very high. Fortunately, there's like demanded natural variance in how teams are, in what subjects or what service lines teams are allocated to, simply by virtue of the fact that, you know, all surgeons don't operate in the same day. Cases are added on or canceled and so on. So there is a natural baseline element of kind of randomness for these allocations. It's not the predominant driver, but, you know, jumping a couple concepts ahead, when we think about trying to intelligently assign nursing staff to rooms, this is something that we are very cognizant of. You don't want to sacrifice your flexibility and ability to adapt. So yes, we are working on that.
Thank you, Hunter. We've got to move on. Great presentation. Lots of interesting questions. We're now moving on to the poster session winner oral presentations that Dr. Matthews announced this morning, or at 12:30. Each of you has 3 minutes. Our first presenter is Ashley Diaz on large tracheoesophageal granular cell tumor and atypical case presentation, location, and management.
And I don't actually see her on there.
No, we have it.
She's here. Oh, she's there. Oh, good. That's right.
We've got a page.
Excellent.
Go for it.
Alrighty. Hello, everyone. My name is Ashley Diaz. I'm a second-year medical student, and I'm really grateful to be able to present this case to you all. The large tracheoesophageal granular cell tumor. Okay. So granular cell tumors are Schwann cell derived, primarily benign soft tissue tumors. They're relatively rare in incidence, with less than 0.05% for all soft tissue tumors. They most frequently present in the head and neck and subsides thereof, so more commonly in the tongue or oral mucosa or other sites of the oral cavity. They can also present more rarely in the gastrointestinal tract, like the stomach, the colon, or the esophagus, but this is around 5 to 11% of cases. More rarely, they present in the trachea, with only 44 cases to date that have reported that in the literature. This is a case of a previously healthy 44-year-old male seen in the emergency department after a motor vehicle accident. He presented with pain in his chest and extremities, and a CT scan showed a soft tissue tumor about 5 centimeters, or a little bit more than 5 centimeters, that was anterior to the upper esophagus and posterior to the trachea, right below the cricoid ring. There were no injuries reported or seen on CT scan from his MVA. The patient, as you can see, has a protruding, there we go. The patient has a bit of protruding mass here in the lumen of the trachea, and it also protrudes into the esophagus here. Despite this narrowing, the patient denied symptoms of dysphagia or voice changes, and there were no shortness of breath symptoms, or he denied trouble sleeping. He was then referred to an outpatient otolaryngology clinic where an MRI was performed, and an ultrasound-guided FNA showed cytology that was consistent with the GCT. The patient underwent a transcervical excision for removal of the tumor, and 6 months post follow-up reported very favorable outcomes and tolerated the procedure well. This is a very unique case from others in the literature because it presents with a large granular cell tumor. Usually these present around 2 centimeters on average in the trachea and other subsites. This obviously is a lot more than that, at around 5 centimeters, a little bit more than that. It also presented between the trachea and the esophagus. Usually these are submucosal lesions, which are very small, and you can usually remove them endoscopically. But in this case, we had to use a transcervical approach, which is kind of rare for this tumor. And GCTs are Schwann cell derived rare tumors that are not often considered on the differential diagnosis of tracheoesophageal masses, and FNA can be very useful for diagnosis, as it was in this case. I'd like to thank my co-authors and Dr. Cipriani, who did the pathology on this case, and Dr. Blair, who was the surgeon of the case. Thank you very much.
Thank you. We have time for one quick question / comment.
Have you written it up yet?
Yes, it got accepted today, actually.
Perfect. Fantastic work from
That's
a
a
medical
great
student,
case.
no less.
I know
Wonderful.
John said just one question, but
Sure,
I figured
go
I
ahead.
could ask one question.
Yes.
So that's a very scary location because that's right where the recurrent nerve is. So kudos to the team for saving the recurrent nerve.
Yeah, they were monitoring
location,
the left
yeah.
recurrent laryngeal the entire time.
Yeah.
No
That's-
damage at all.
Yeah, that's fantastic.
Yeah.
It's amazing. It's asymptomatic. Great. Thank you.
Yeah.
Okay. Next on our docket is Dr. Jonathan Kent from the Madariaga Lab, differential metabolite utilization between non-small cell lung cancer and healthy lung tissue detected by intraoperative AV sampling.
Hello, everybody. I'm thrilled to be here representing the Organ Perfusion Lab, and we are very excited to share some of our preliminary results with you. So to understand where we're going, we're quickly going to go over where we came from. Arteriovenous sampling as a method of evaluating tumor metabolism is not new to cancer biology. It actually was initially started back in 1925 by the husband and wife team, Corey and Corey, when they found that there was an increased relative concentration of lactate in the vein draining a chicken wing with a sarcoma in it relative to the contralateral healthy wing. This was expanded upon by Warburg and ended up being the basis for the Warburg effect and eventually FDG PET imaging. We've since moved away from this relatively invasive method of evaluating tumor metabolism, but our current methodologies are limited by measuring relative concentrations of metabolites, being analysis of resected tumor specimens or in vitro cells, as well as not being as comprehensive. So for these reasons, we hypothesized that in vivo arteriovenous sampling will demonstrate higher accuracy in detecting metabolic consumption and secretion of non-small cell lung cancers than conventional methods. For this pilot study, we are recruiting 25 patients with resectable non-small cell lung cancer. And at time of oncologic resection, we are taking serum samples from the pulmonary artery, the pulmonary vein of the affected lobe, the pulmonary vein of an unaffected lobe, a radial artery, and a peripheral vein. And we use this pre and post circulation blood flow to approximate the metabolism of the non-small cell lung cancer tissue, healthy lung tissue, and systemic circulation. We are then able to take these serum samples and through LCMS, quantify the absolute and relative concentrations of 155 different unique metabolites. So with our first interim analysis, we have found that overall plasma metabolite composition is more similar within patients, as shown in the PCA on the left, relative to by site sampled on the right. And we are starting to see some trends towards differential concentrations of metabolites in veins draining cancer-containing lobes relative to those draining healthy tissue. And in this graph, we are showing that on the right in red, metabolites that are found to have relative increases in concentration in the vein draining cancer-containing lobe relative to the healthy lobe. And in blue on the left, we are showing the different metabolites that have decreased concentration. Notable in this, we noted increased concentrations of lactate, as well as some increased secretion of amino acids, including arginine, serine, and tyrosine. None of these are statistically significant with our N of 4 so far, but we are hoping that as we continue to accrue patients, we will start to see some statistical significance. We now have recruited 9 of our 25 patients. We are looking forward to doing further analysis on serum samples, including lipid composition, heavy metal composition, and then we have samples of tissue as well as interstitial fluid that we're looking forward to analyzing. And I have many people to thank, but I know we are kind of crunched on time, and so I'm happy to take a quick question or have any questions at this time.
Wonderful. Thank you very much, Dr. Kent. Are there any questions, comments?
Do you help me understand? So what's the play here? The idea is that you're going to use this for localization, to enhance localization, to look for small metastases. What's the game plan?
So
what are you driving towards?
One is that we are trying to better understand the metabolism of the cancer so that we hopefully can find a new target for a targeted therapy, blocking a differential metabolic pathway that drives tumor growth relative to healthy lung tissue. And the second is if we find that there is something that is secreted preferentially by these tumors relative to healthy lung tissue, that's something that we could use for a diagnostic modality.
You know, it strikes me, there's a big group in the Netherlands looking at exhaled gas and doing gas chromatography. I wonder how this might jive with those findings. It'd be really interesting to be able to pair them because that's non-invasive.
I would have to sort of look up those findings. I'm not as familiar with that work.
But you're going to become.
But I am very interested to look at it.
Just like the experiment I'm going to do next month.
Yeah, exactly.
Okay, wonderful.
All right, thank you.
Thank you, Dr. Kent. Good job. Last is Jared Pollard from the Chong Lab. Graft matched pregnancy imparts profound epigenetic changes onto alloreactive memory T cells to enforce a phenotypic and transcriptional state of tolerance.
Hi, everyone. I am very sorry that I couldn't make it to be in person today, but I'm honored to have received this award and I'm really excited for the opportunity to present. So I won't repeat my title because it is quite a mouthful, but I'm going to share my screen here and make sure that everybody can see it okay.
Looks good.
Okay. Are people seeing the presenter view on accident?
Yes.
Yeah.
Okay. How about now?
Perfect.
Better? Great. Okay. So I'll go ahead and jump right into some of the background for this project. So our background, we're much more of a translational lab. So my work is leaning a little bit more towards basic. But background for this project is that immunological memory is a major barrier to transplantation tolerance in the clinic. At present, no successful methods have been identified to induce tolerance in memory T cells. And we and others have been previously reporting that pregnancy can program hypofunction into naive T cells, which can result in spontaneous tolerance to offspring match allografts in the absence of B cells and antibodies. And so my aims for this project is to test whether pregnancy can program hypofunction, the same hypofunction we saw in naive T cells, into memory T cells, which could potentially result in extended survival of these fetus match allografts. And then additionally, we wanted to characterize how it's happening via transcriptional and epigenetic modifications, investigating these. So briefly, our experimental model involves B6 female mice as recipients, and the donor mice is a full mismatch BALB-C with a xenoantigen of 2W ova fusion protein, which allows us to track antigen-specific T cells and B cells in our recipient model. And so our experimental model involves the full cross-section of both skin sensitization or no skin sensitization, and then mating with a semi-allogeneic pregnancy or no mating. And so our final 4 experimental groups are naive T cells, which receive no skin and no mating, and then naive plus postpartum, which is no skin plus mating, memory, which is no skin sensitization, no mating, and memory postpartum, which is skin sensitization and along with a semi-allogeneic pregnancy. So our first step is we needed to confirm that pregnancy did occur at successful rates in sensitized animals. And we did see that in skin sensitized recipients, they were able to undergo a successful pregnancy at the same rate as a naive recipient. And then additionally, we adoptively transferred T cells from either skin sensitized or skin sensitized plus postpartum recipients into naive hosts. And upon giving these naive hosts a semi-allogeneic heart graft, which was fetus matched, we saw that there was a significant extension in graft survival time in animals that had received memory sensitized plus postpartum cells rather than mice that had been adoptively transferred with only skin sensitized cells. So we did see that pregnancy is causing a significant extension in graft survival in these adoptively transferred hosts. So next is that we wanted to characterize the proteomic effect on the fetus-specific CD8s that pregnancy was having. And so via a 20-color flow cytometry panel, along with dimensionality reduction and clustering techniques, we were able to see that pregnancy is heterogeneously reprogramming fetus-specific CD8s. And so you can see here, and it's confirmed via flow-sum cluster analysis, that there is the presence of this shared phenotypic signature that exists in both a naive pregnancy and a pregnancy after a skin sensitization. And this signature is defined by co-inhibitory markers such as PD-1, LAG3, and TIGIT. And so next, what we wanted to do is we wanted to characterize the transcriptional and epigenetic impact of this. And so we saw that across the entire genome, rather than our initial flow cytometry panel of 20 markers, we saw that the clusters that appeared in proteomics also were present in the transcriptional signature. So you can see that this naive postpartum cluster 5, which was the red cluster we saw previously, also appears very transcriptionally similar to the memory postpartum cluster 5. And this is confirmed via heat map, where you can see that there is a large range of shared transcription in naive in CD8s in naive or a memory postpartum. And so we were expecting to potentially see that the epigenetic landscape was also going to be similar in these animals. And so we assessed this via ATAC sequencing to assess the chromatin profiles. And shockingly, we found that the epigenetic landscape was actually completely distinct in memory postpartum, and notably that the clusters that were transcriptionally similar are actually epigenetically completely distinct from one another as assessed via ATAC-seq. And you can see that there's significant both opening and closing of chromatin accessibility in a memory postpartum animal. And so we wanted to address this a little bit more concretely. And so we assessed in regions where the transcriptional behavior was the same. So in regions of this shared transcriptional upregulation or downregulation that was the same in naive and a memory animal after pregnancy, we saw that there was actually a much greater requirement for chromatin opening for RNA upregulation or for chromatin closing in RNA downregulation, respectively. Which means that the requirement for epigenetic modification is much greater in a memory T cell than in a naive T cell to achieve the same transcriptional outcome. And so our conclusions from this whole project is that from our first figure, that pregnancy can successfully restrain fetus-specific T cells and enhances the susceptibility to co-stimulation blockade mediated transplant tolerance. Additionally, that pregnancy is reprogramming both the phenotype and transcriptome of naive and memory T cells equivalently to result in shared transcriptional and phenotypic signatures. But interestingly, that there's a significant increase in epigenetic modification that's required in memory T cells to induce this same transcriptome and phenotype as the naive T cells. And so our future directions for this are to identify what these pathways are, both transcriptionally and epigenetically, that pregnancy is inducing, and possibly to find targetable therapeutic pathways of what is causing this enhanced susceptibility to co-stimulation blockade. And then additionally to define this fate in the CD4 T conventional cells to see if there's a way that this can be utilized for enhanced transplantation tolerance in the clinic. Thank you very much.
Thank you. Nice job.
Thank you.
Complicated topic. Are there any comments, questions? We have time for one.
That's really incredible work. Let me ask a really dumb question. How long does the effect last after the pregnancy? Do these models last?
That is an excellent question. So that was one.
I was afraid it was a stupid question.
No, absolutely not. Because that's, I mean, it's very important because, for clinical relevance, we're not necessarily going to be taking mothers who have just given birth and, giving them an organ transplant or anything of the sort. So we had some very preliminary data a while ago that assessed at day 30 plus after pregnancy to see if these effects remained. And we did see that at least in flow cytometry, so in the phenotype, that most of these changes did remain at day 30. But we decided just this project is a beast enough as it is. So we've decided to limit the scope of our project for now to the day 0 effect. But some of that initial data that I mentioned in the background was assessing the effects of pregnancy in naive T cells, at least at day 30 and day 60. And those effects did have somewhat of a longevity.
Thank you very much, Jared. I'm just really impressed by your fluency in this topic, which is very complicated. Congratulations, you're doing great stuff. Let's now move to our featured topic on education and another featured topic on diversity, equity, and inclusion. These are both exciting topics, and I think there'll be a lot of comments about them. Our first is by Tyler Dunn. 3D printed custom designed tissue engineered vascular graft provides optimal attenuated neointimal hyperplasia and flow dynamics in porcine pulmonary artery reconstruction model from the Hibino lab. A title that might be longer than the one from my lab.
Very nice. Quite a mouthful. But,
Okay.
Thank you very much.
Go ahead.
Thank you for this opportunity. I really appreciate it. So we're going to start off with a little bit of background on vascular reconstruction and the importance of patient specificity on ideal outcomes. And to do that, I have an example of one of the most common single ventricle surgeries, the Fontan procedure. As you can see from the 3D reconstructions and the graphs depicting flow distributions of 6 different patients, there's great variance in terms of anatomy and resulting physiology. Generally speaking, prepackaged grafts are used by surgeons during many vascular procedures, and the difficulty of orienting those grafts properly during implantation greatly impacts patient outcomes. So complex vascular reconstruction remains challenging due to the surgical orientation and unique 3D geometries of each patient. However, tissue engineered vascular grafts, TEVG, possess not only excellent anti-thrombotic and anti-infective properties, but also emphasize the ability to match patient anatomy and grow with the patient as they mature. So flow distribution is greatly affected by surgical implantation, as well as the type of graft utilized. As shown in the central figure, the surgeon anastomosis site is intraoperatively adjustable and can significantly impact the resulting flow distribution and wall shear stress. 3D printed patient-specific TEVG map patient anatomy and design a graft in which hemodynamics and flow are optimized for improved patient outcomes. Optimization of the graft to equally distribute flow and decrease wall shear stress are crucial for graft manufacturing. So the aim of our study was to create a 3D printed custom designed TEVG demonstrating optimal anatomic fit, maintaining ideal flow dynamics and neotissue formation in the porcine model. We sought out to achieve this goal by applying our unique 3D printed technology to create patient-specific TVG for the right ventricle pulmonary artery surgery, or VPA. So a little bit of background on our method. We acquired MRI and 4D, four-dimensional flow data for the native anatomy of pigs to design a patient-specific TVG of the pulmonary artery 4 weeks prior to the surgery. Optimal shape of the branch vascular graft was designed using a computer-aided design, CAD, informed by computational flow dynamics, CFD. So we optimized the grafts given data collected through MRI, CAD reconstruction, and CFD simulation for the purpose of reducing both energy loss and wall shear stress. The goal of patient specificity are those two outputs, and given the ability to calculate energy loss and wall shear stress for each patient, only grafts with the lowest values are manufactured and implanted. So here's an overview of the procedure we enacted. A pre-op MRI was taken, the graft was optimized, the graft was manufactured, the graft was implanted, the post-op MRI was taken, and finally the graft was explanted for evaluation. The post-op MRI and flow dynamics were evaluated and compared to the pre-op MRI to determine outcome success. Additionally, histology was performed on the explanted graft and neointimal hyperplasia assessed through measuring both the graft and the native tissue. So the MRI at the endpoint showed encouraging flow dynamics and survival for all pigs. As you can see from the left figure, velocity, wall shear stress, and energy loss were similar pre and post-operatively. The images of velocity and wall shear stress show very little red, which indicates high flow pressure, respectively. Green indicates low values, and similarly, energy loss throughout was also minimized. These are critical in achieving the end goal, which is equal left and right pulmonary flow. This is shown in the bottom right graph for pre and post-op average flow or balance. In this data, we have determined that low wall shear stress and energy loss values are critical for flow balance. Another important aspect of wall shear stress is the resulting impact of neointimal recovery. Low wall shear stress demonstrated a significant correlation with decreased neointimal thickness through histology. This suggested that optimal shape and design are important for appropriate native tissue formation. As you can see from the two histological photos, the black line depicting the suture line, thickness is similar for graft and native tissue. Furthermore, average neointimal thickness for native tissue and TVG were measured and similar for all groups, as shown in the bottom right graph. From the postoperative data collected, we were able to conclude that increased wall shear stress led to thickening of the neointima. So, as long as we can implant the ideal design, the lowest wall shear stress, neointima is very similar to the native tissue. If we do not optimize the design for hemodynamics, we kink the graft or implant improperly, non-ideal outcomes can occur. So in conclusion, our 3D printed custom designed tissue engineered vascular graft, TVG, demonstrated optimal anatomic fit, maintaining ideal flow dynamics and neo-tissue formation in the porcine model. Thank you very much.
Very nice presentation. Beautiful illustrations. Well done. Are there any questions?
Yeah.
Forgive my ignorance, but so currently I know there's customized grafts that are made, but are any of them, I mean for humans, are any of them actually 3D printed currently, or is this the beginnings of that?
The relevance in the human surgery, Dr. Urbino, I'm going to defer to you in terms of that one. Do you have a comment on the TVG and human surgery?
I don't think there is any such commercially available custom graft in vascular surgery field. So if you implant some graft into some scapular implantation or some other mandibular, those field is now in commercial available, going studied. But in the vascular field, it's really behind because of the not just anatomy. We need to think about the blood flow through there. So that's why we added some hemodynamics information when we designed the patient specificity. And also, and when we implant just a tube doesn't work. You need to create a tissue at the same time. So those things are the focus in our research.
We have a question for
Dr. Paris, yeah.
Yep, she's asking, what is the material of the graft?
Yeah, so that would be PCL and PGA, polyglycolic acid.
So can I ask a dumb question? Maybe Luca's here. What's the difference between the approach that you're taking in your lab and the approach that's going on in the Havana lab? I'm trying to reconcile the analysis and, sort of the strategy. You're both trying to optimize graphs. So what's the points of synergy and where's the divergence here?
I think one of the key points that I might be able to talk about is kind of the dynamic aspect that we're trying to reconstruct. Like what are the flow dynamics while the heart is beating? I think you mentioned earlier, there's more of a static view from the CT scan. So I'd say that might be one thing. I don't know if you have anything to add to that.
You want to comment?
So Mira and I have a few projects together. Overlap.
Here, let me toss it to you.
So, I mean, we have a few projects together, CFD for me is relatively new since we mostly focused on finite element and elasticity modeling, but we have brought now XFlow online here and it's implemented on Gardner, our HPC cluster. In the real world, right, both of those two things couple. So the fluid is how load is transferred to the vascular system. Here, there's a large focus on shear stress, which probably in the venous system is true. In the arterial system, pressure is the more dominant parameter, right? So if you need to go through all so for instance, to do an entire coupled fluid structure interaction simulation may take weeks to even get 3 beats of the heart simulated. So what we're really focused on is how can you do a CFD simulation, extract out the pressure information, right? And then move that into, for instance, a finite element code where you can now model how that pressure would influence the deformation of the aorta. But there's things that we're actively working on together.
Yeah, very similarity. Lucas very small, so that I always learn many things from him. But just simplify that. Lucas doing a more we both are working toward the patient specificity. So patient specific analysis. And then he's working for more kind of real vascular analysis. We are trying to create a device based on that information. That's a kind of different direction, but we have very similarity in many ways. So that we are very exciting working together.
Yeah, that's great. Thank you.
Okay, wonderful. Thank you very much. On to our next interesting topic, featured topic, on diversity, equity, and inclusion by Stephanie Washington from the Zackerson Lab. Trauma patient perspectives on crime victim compensation and post-discharge implications. Ms. Washington, I don't know who you are. Yes, I do.
Yeah.
Hi, nice to meet you.
You as well. Let's see how far I can get without my glasses getting all fogged up.
You can take your mask off. You can take it down. Yeah.
So hello everyone. As mentioned, my name is Stephanie Washington. I'm a second-year medical student here at the University of Chicago, and I am incredibly honored to have the opportunity to present to you all about our patient perspectives on crime victim compensation and the implications post-discharge. And this ongoing work would not be possible without the support of my mentors, Doctors Elizabeth Tung and Tanya Zackerson, as well as the members of the Praxis Research Collective. Hurt people hurt people. This is a phrase used by many gun violence survivors and advocates for change. We see this vicious cycle of violence play out here on the South Side, with adult trauma volumes steadily increasing each year. In the first year of operation, the trauma center here saw almost 3,000 adult trauma patients. That number has since increased by over 70%. With record-breaking trauma volumes are seen each year, especially during the summer months. And here at U Chicago, gunshot wounds, or GSWs, remain the #1 mechanism of traumatic injury. And this is unique, as most other trauma centers experience blunt traumas as their primary presenting injuries. So with all this trauma, we ask, what are the needs of our trauma patients post-discharge? And why is this important? We need to focus on this because when we identify the needs of patients and their families, we are able to improve health outcomes and reduce harm. It's the possible post-discharge needs of patients are plentiful. And in 2019 study by Creatinine et al., the research team sought to understand the post-discharge needs of victims of gun violence specifically. And through interviews of 10 patients, the study corroborated some of the needs we've identified on this slide. However, to date, no study has quantified this data in a meaningful way. And in our own qualitative research through praxis, one trauma patient said the following when asked about where they go for support. My family, I talk to God, I cry and just let it out. I cry for support, I just cry. So talking about crime victim compensation, the mission of crime victim compensation was inspired by a proclamation given by Ronald Reagan in 1982. He said, the innocent victims of crime have been overlooked. Their pleas for justice have gone unheeded, and their wounds, personal, emotional, and financial, have gone unattended. Now, interestingly, this program originally, when it began in the 80s, it targeted middle-class survivors of domestic violence. So flash forward to today, the Illinois Crime Victim Compensation Program offers up to $27,000 to victims. And as of August of this year, will begin to offer $45,000 for victims and their families to help cover costs related to their injury. This could be hospital visit costs, medicine, relocation costs, mental health support, lost wages, and if necessary, funeral costs as well. So let's talk about who is eligible. A victim by the Illinois CDC program is defined as not only the person injured, but many individuals that surround the trauma as well. And based on these criteria, many of our patients here on the South Side would likely, and their families would likely qualify for this program. Unfortunately, there are some stipulations. This person injured is qualified unless staff and or the police determine that they were contributing to their own injury. And this could be by engaging in wrongful acts, perhaps being labeled as a gang member, or by provoking the offender. If a person is deemed to be uncooperative by the police, their application would be denied as well. Additionally, the crime must have occurred within 72 hours, pardon me, the crime must have been reported to law enforcement within 72 hours, and the application cannot be submitted any later than 2 years after the incident. So for example, if you're sitting here today and you just learned about this opportunity, this program, but you were injured 5 years ago, unfortunately, your application wouldn't be accepted. However, there is a new Illinois Safety, Accountability, Fairness, and Equity Act, or the Safety Act, that was just recently passed with the support of Attorney General Kwame Raoul that's working to extend this time frame. Another barrier to crime victim compensation is the application itself. Multiple forms must be completed and full cooperation with the police is required, and the application is currently not available online. All this must be completed via snail mail. It was recently reported by the Alliance for Safety and Justice that really only 6 out of every 100 crimes that are reported to law enforcement result in an application. And when they asked who were the individuals who were applying, it was found that most applicants were white, middle-aged, English-speaking men, which statistically speaking is the least victimized group in the United States. So again, I want to return to the question, what do our trauma patients need post-discharge? To address this question, patients were recruited using a consecutive convenience sample here at the University of Chicago during their follow-up visits in the trauma clinic. Patients were offered the survey through Qualtrics on a tablet. It took patients between 20 to 30 minutes to complete, and it had 75 items. And once patients returned the tablet, they were offered a $20 Visa gift card as incentive. And our target population size is 200 participants. Now the the survey consists of 4 modules, 3 of which are from validated instruments. We have the social needs screener and patient satisfaction survey from the Center for Medicaid and Medicare Services, and a PTSD screener from the VA. Our final module is a resource needs, and these are adapted from NowPow. NowPow is a really awesome personalized community resource referral platform where providers can prescribe a list of resources that are relevant and personalized to the patient based off of location and needs. So here's a table of our demographics, and when you look, you can see that the majority of our patients are young Black men, with over 70% survivors of gunshot wounds. This is starkly different than the demographic who's currently applying for chronic victim compensation. So during the survey, participants were asked about their need versus utilization of 5 broad categories of resources. Now, we did find the largest discrepancy between need and application of crime victim compensation. And because of that, that's what we're going to be focusing on for this project. But we will focus on the other resources in future projects as well. So we wanted to know what was the baseline knowledge of crime victim compensation. And when we asked patients, 3/4 of our participants were not aware that this program existed. And after giving a brief description of the program and its possible benefits, should you qualify, 72% of patients said, yeah, that's something I feel like I would benefit from. So to take a step back and give a broad overview, thus far we've surveyed 61 participants, and of those, 46 would likely qualify based off of their mechanism of injury. However, only 7 reported applying to the program, and only 1 individual reported receiving benefit from this program at the time of the survey. So we're wondering, how could this be? Why are patients not applying for crime victim compensation? And the top 3 responses were simply, I was not aware of this resource, I didn't know how to access this resource, or I couldn't find the application. We as a country, state, city, and hospital really need to invest in the recovery of our survivors. And it's shocking that a very small percentage of participants reported having just one of the resources met after leaving the hospital. And crime victim compensations were severely underutilized by victims of violent injury. And this could be due to the historical poor dissemination of the information by the state. And additionally, the lack of accessibility. Not only is the application hard to find, it's a very cumbersome process to go through. We need to have interventions that are aimed at patient and provider education to help decrease the gap of knowledge to get this program and the knowledge of this program out there. Additionally, we need to hold our state and government accountable and improving access and awareness of this program. Now, to address some limitations of the study, it is a small sample size, but despite this, we were able to detect some statistical significance. The data collection is ongoing with a sample size goal of 200. Additionally, although this data was collected here at the University of Chicago at one trauma center, we expect it to be relevant to other trauma centers with high rates of violent injury as well. And probably most significantly, we surveyed a very specific group of patients. These were patients who were able to return to the clinic. As many of you may know, the trauma clinic here experiences a pretty significant attrition rate due to the numerous barriers that patients face while returning to the hospital. And so we are currently working to extend recruitment via telephone because we believe that the estimates that we have are conservative, because those who are unable to return to clinic may have even less access to these resources. So what's next? We will continue to survey patients and learn more about their experiences and perspectives, and we also need to work to improve information transfer between provider and patient. In that same vein, we need to make sure that patients are receiving this really important information in multiple modalities. So not just told to them once, or not even just written on their discharge forms, but told in multiple ways, because just the time of discharge is a busy time, and the information gets lost easily. So on a national level, we need to make sure that crime victim compensation is worked into other trauma center operations, perhaps including it as a metric of the American College of Surgeons Committee on Trauma Center Verification process. And we need to remember that we have to also hold the state accountable for protecting its citizens. Now, Amnesty International is a UK-based organization, and they cite gun violence as a violation of human rights. Additionally, they say that not meeting survivors' resource needs is a violation of those rights as well, saying all victims of human rights violations have the right to effective remedy. And I'd like to close on a quote by one of my colleagues, Paige Ashley Campbell, who's a fourth year here, saying, as healthcare providers, survivors, activists, and organizations that experience the harsh realities of navigating the compensation system, we often wonder how we might interrupt this pattern. Thank you all so much.
Wonderful presentation. Congratulations.
I'd also like to thank all the members of Praxis. It's a multidisciplinary group of survivors of violence, physicians, trainees, medical students, community members. It's a really wonderful group, and we would welcome you to join us in one of our meetings.
Great. Are there any comments or questions?
Many. Yeah, many, I'm sure though. So Stephanie, I'll start off with what a great presentation. You're obviously dedicated to this cause and passionate and a great researcher. So I have one question. What part of this, or do you think is more practical? Like, could a social worker give the actual form, since no one knows where to find it, it seems, to the victims on discharge, or actually help them fill it out and whatnot, versus how much of it is bias? Like, obviously if 87% of the victims are African-American men, but all the ones who apply are white middle-aged men, then there has to be more than just implicit bias. There's explicit bias in preventing them from getting into the system because they're viewed as who created the crime or whatever the issue is.
That's a very brilliant question. And I think one that I don't really know the answer to. I can only speculate. And I would say that it's a little bit of both. I mean, if you've been in any trauma center, I'm sure, especially here, it's very busy. And we do have social workers here, part of our violence recovery program. There's social workers who are very well versed in all of these resources, but they see such a high volume of patients that it's very hard to sit with them and make sure that they're hearing this information. And so I think part of it is we need more social workers. We need more people who are very well versed in this topic. But at the same time, it is that explicit bias, like you mentioned. It's no longer implicit.
No, carry on. I'll just comment.
It's no longer this implicit bias that's very clearly against how lawmakers may view the cause to the problem and not necessarily worthy of being part of the solution. So all that to say, as I wish I knew the answer, that would be really great.
And actually, thank you, Dr. Perengi, for your question, and Stephanie, excellent presentation. It's a very good question in the sense that we don't know precisely where the barriers lie. So we actually have a Robert Wood Johnson grant to specifically study this, because as luck would have it, we do, since 2019, we do have an attorney general who is interested in addressing the barriers related to structural racism. An example, as Stephanie mentioned, if you are a trauma patient who happens to be in the City of Chicago Police Department gang registry, which includes people from the age of 9 to 82 years of age, 95% of the people in this registry are people of color, then you automatically do not qualify for crime victim compensation. So Kwame Raoul has said we're doing away with these barriers. But what are the other barriers? We don't know. What we do know is it's hard for us to rely on our local violence recovery specialists, our social workers in hospital. They're already overworked. And especially with COVID and trauma increasing, we kind of, our intervention is more on the government end to say, these are where the barriers are. You have quite a bit of money. Let's work together and let's fix them, at a upstream, as it were. But thank you for your question.
Stephanie, that was a really great presentation. And obviously, I've heard this before being on the trauma research meetings. I think one of the questions and things I struggle with when I think about this is, even for somebody in our community who would potentially get this amount of money one time, which could be exponentially more than they even make in a 1-year period, how do we make something like this a long-term solution for people? Because you would think like providing financial assistance to even deal with an amount of money this big would be really important. And, a one-time dose of this solution doesn't really prepare somebody then for the next 5 to 10 years of their life, especially when we're talking about young men who need jobs, et cetera, to, you know, carry on. So I'm just curious how you kind of see this being incorporated into the big picture.
Great question, thank you. I would say, just like you said, prime victim compensation is a very small piece of the larger puzzle. And I feel like really have to give credit to existing community organizations whose work is to make sure that these individuals are kind of protected and given a space to heal, and given the opportunity to, like you said, find income and find these new jobs. And there's a lot of community organizations that this is their mission, but people aren't aware. And I think a big thing is that perhaps when we're thinking about what can we do, it's like educating ourselves and on what the community can offer, and also utilizing our social workers to make sure that once, yeah, you get that one-time payment or the reimbursement of X thousands of dollars, but then like, here, let me introduce you to so-and-so who's leading this group, who can help you relocate and settle in and find a job in this new space, and also make sure that you're following up with your mental health or whatever you need. So yeah, I agree completely. I say, though it's, you know, it was presented here as a really amazing, or this big program that everyone needs, yes, but it's only a small piece of that road to recovery.
And just very quickly to add to that, we're actually fortunate enough to get the Department of Justice grant, which will work on establishing a trauma navigator, which has legal supports from the School of Law, but also financial advisors, in addition to people who will apply for this. Because you're right, we have to be careful and cognizant that we have no right really to tell patients like, oh, you're only allowed to use the money on this and that. But absolutely, if we really want to get to the root of the harm, which is the racial wealth gap, then by supporting, you know, the survivor of violence and the immediate family members, you're talking about $250,000 per family, which would actually go a long way. So having the resources to support them in making the decisions that they would like to make for that, I think would be a way to actually protect the siblings and other family members from future trauma, in addition to addressing the wealth gap.
Like everyone else.
We have a few questions from, I think James Oyenedi wants to make a comment. James, are you there? Go ahead.
Yes, I am. Thank you, and great presentation, Stephanie. You mentioned a lot of great points, but one of them that really stuck with me was access. And while we have most of our patients come in, they do see violence recovery. Sometimes they see a social worker at that initial visit. Has there been any investigation or looking into how do we get social workers and violence recovery to actually be present in clinic with us when these patients come back, to try to foster better follow-up with these social services that are available to them?
Yes, thank you. From what I've seen since, so the data collection began last summer. And when I would administer these surveys, I would always ask patients whether or not I complete the survey with them, do you have any questions? And it's amazing the number of people who said, actually, can you tell me more about this program? And I would then call our VRP or our violence recovery specialist on call. And I would do that, probably annoyed them a lot, just kidding. But they ended up, I was just recently in the trauma clinic, and they now have a role for a violence recovery specialist in every trauma clinic. So now there is someone who's on call, like you mentioned, at least during clinic, who can connect people and make sure and follow up with individuals and make sure that they're well connected.
Stephanie, again, like everyone has said, this is a fabulous presentation. You're very passionate about the subject. That's very appreciated. You have perfectly up here on the slide the marker of $45,000 as the maximum amount that is given. And my question is, how transparent is the state right now with how much they decide to give up to that limit, and in terms of their justification for that process, as well as for those that are ultimately denied? Are they denied and that's it, or are they told why they were denied?
Yeah, really, really great question. I'll start with the transparency. Not really, yes and no. I would say that with certain things, so on the website, it's very clear that if you are using the funds for bereavement costs or the cost of funeral, you have up to $7,500. It does specify with like, I'm trying to think of the other numbers, like it kind of specifies in that way, but it never really goes into, so I actually, in my research found through a Trace article that looked at the data, the big data that wasn't really presented well on the website of the state, showing that really like a third, I think the majority of awardees received less than a third of the funding. And there are caps, like I mentioned, with the funeral costs, but very, very, very few individuals actually receive this big fancy number on the screen. And with that, so when people get denied was your second question. Again, not something that I found on the state's website. That was actually another article. Someone pulled the data and saw that they do give very vague reasons as to why you were denied. And I can tell you that the majority for Black and Hispanic individuals was that idea contributed to injury.
Not surprised. Great. Dr. Matthews, do we want to?
No, we got another minute and a half or so before we need to transition.
Okay.
Can I just ask a couple questions? So this is an Illinois thing. How many states have this?
All of them.
All states have a crime victim compensation, and are all as dysfunctional as Illinois,
Yeah.
where most people are deemed ineligible from the outset, and only 1 in 7 completed applications ever get funded, and you have to do it, by snail mail.
Yeah, I would say.
That seems like it's an intentional thing.
And try to leave a message. Their mailbox is full.
Yeah, always full.
Like it's mind blowing, to be honest. But do you want to comment on this, Stephanie?
Yeah, sure. Unfortunately, from what I've seen when I have done brief research into other states, that say all the systems have their problems. However, Pennsylvania, which is my home state, has the application online. So there's that, but in general, yeah.
Seems like an opportunity for the advocacy work group to start writing some editorials about this, maybe do a podcast on it.
Yeah.
Get a little bit more, sunshine on this. Do you
Yeah,
want
so
to make a comment?
we have that Trace article that we wrote about. Oops, sorry. But we wrote about it in the Trace, and I think some of this funded work will really go towards that. What's interesting is the Department of Justice houses the people who oversee on a national level the Crime Victim Compensation Program. So we're meeting with them shortly, but it will really be telling in terms of the processes of highlighting the barriers here locally in Illinois, because quite honestly, moving forward, there's no reason why this should not be a quality metric for all level 1, 2, and 3 trauma centers, and that you have to show at least the initiation of the application process for 75% or plus of your injured trauma patients who have been affected by interpersonal intentional injury or some such thing. But I don't know if we actually know state by state. Yeah.
There's a question from the resident workflow.
Wait, the residents ask, has the effectiveness of monetary compensation for victims of violent crime impact on recidivism or recovery from trauma been studied?
Another research question.
That's what I'll be doing.
Weekly. There's some signal that there is less re-victimization. Once someone is victimized, again, the language may not be the best. Once someone is victimized, there's a high sense of fear that you're vulnerable to repeat victimization, repeat injury, because you're, interpreted to be a sucker or a whole bunch of different social factors and whatnot. So we find that actually the financial support can be protective against the act of becoming re-victimized in the neighborhood. There's actually some evidence with John Mackey's Alliance for Safety and Justice work that rates of PTSD actually might go down. It's all kind of weak signal, not robustly studied. But yeah.
Great. Thank you. That's a great, and obviously we could and should have more discussion on this this issue. All right. So could I get my last slide up for my presentation too? Yes. we're going to transition over to our keynote, the highlight of our day, the highlight of many highlights. Yeah, this one's good. What do I do? No, that's her. Do me first. Just get her shiny. Great. All right. Well, it's 4 o'clock, or it's 30 seconds before 4 o'clock, and the time has come for us to move over to our keynote address. And every year, at least for the last 16 years that I've been here, we invite very deliberately a surgeon scientist to come and give the keynote for the Huggins Symposium, somebody who will inspire, somebody who has walked the walk and knows how to talk the talk in this area, and somebody who can connect with our team here to both show off what we're doing here at the University of Chicago and also impart some wisdom and inspiration for us as we continue to move forward. And this year, we have somebody who I've wanted to bring for quite some time to the University of Chicago for exactly this reason. And we had a great excuse because her son is at that other school up the street. So this was it's worked out perfectly for us. Dr. Saray Parengi, somebody I've known for at least 25 years, I think now. She is an extraordinary endocrine surgeon, specializes in thyroid cancer. Her path to leadership is fascinating, and I don't know how much of this is you're going to tell, but she came to the United States, what was it, at age 12? Did I get that right? Escaping Iran right around the time of the revolution, and became an outstanding scholar, went to Barnard and then Columbia Medical School, then trained at UCSF, was a co-resident with Dr. Jaskowiak. And then when I was still at the Beth Israel Hospital in Boston, we were lucky enough to recruit her, I think maybe my 4th year or something on faculty. We brought her in and she was one of the young Turks with us coming into that department, getting her academic career going. She did extraordinary research as a resident and beyond. She worked with some of the really legendary figures in the field of angiogenesis. She worked with Doug Hanahan, Jack Lawler, and Judah Folkman, and published some extraordinary work in her early career coming out of that. And then really established and rose up through the ranks at the Beth Israel Hospital, and then moved over to the Mass General over the last decade or two. And worked her way up to be only the 2nd woman professor of surgery at the Mass General in their history, and has continued to grow in leadership profile. She plays leadership roles in many organizations, including an officer of the American Association of Endocrine Surgery and a recent past president of the Association of Women Surgeons. She's really, as you've heard throughout the day, very insightful on all matters related to modern surgery, not only surgical science, not only clinical surgery, but also our challenges in increasing diversity, representation, and the social context in which our departments are growing and learning how to thrive. So we're really excited that she's here today. She still operates at a Mass General, still big professor at the Mass General at Harvard, and she's now got a new administrative role in addition as chief of surgery at Newton Wellesley Hospital. For those of you who don't know, Boston is one of the sort of premier community hospitals that's within the MGH Partners, or they don't call it that anymore, do they? Orbit that's there, and these hospitals are all very close together. So she continues to have an incredible career as a surgeon scientist and as a leader in American surgery, and a dear friend for decades now, and just thrilled that you're here.
Thank you, Jeff.
Thank you so much. It's amazing to be here and to hear all these presentations and really listen to all the great work that is the legacy of the Nobel Prize winner whose name I'm here representing today. So thank you for inviting me, Jeff. It's really been a huge pleasure. So you guys already heard about Dr. Huggins, so I'm not going to go too much into this, but I did want to kind of point out that, you know, he did win the Nobel Prize for not just the discovery that prostate cancer cells are dependent on hormones, but he translated that work into patient care, directly into the patient care of prostate cancer patients and then breast cancer patients. And he also really did the first animal model of breast cancer in rats, which I think is important to some of the work that I'm going to talk about. And it's also important when you look at it, these are all the surgeons who have won Nobel Prizes. Interestingly, my husband's a urologist, and he points out that 2 of them are urologists. So Dr. Werner Forsman, the first cardiac catheterization, was actually a urologist, it turns out. And then, of course, Dr. Huggins. And then everything stops in 1990. I mean, really, everything was being given every 20 years at the latest. And then suddenly in 1990, things stopped. And so I think it's important for people like you to continue the work and really make this happen again. So we can't let this stop anymore. And I actually got to hear Dr. Murray speak before he passed away. He came to UCSF once and gave a talk, and it was incredibly inspirational. So I'm going to talk, it's just a little bit of an oddball talk, and I hope that people enjoy it and don't think it's totally strange. But I'm going to talk a little bit about hope and resilience. With hope really is something that we see our patients have when they're facing really bad problems, like the patients presented today with the nephrostomy tube and all kinds of problems. Both hope and resilience are protective psychological traits. And hope is really an optimistic attitude of mind that has to be realistic, right? Otherwise you would get some DSM diagnosis. And you have to be able to believe that you can produce routes to your desired goals. Resilience, on the other hand, is an adaptive response to hardship, stress, and adversity, which has these general components: adaptability, purposefulness, bounce back. And resilience in our field in healthcare definitively correlates with success, personal satisfaction, happiness, and the longevity of our practice. And so it's for this, these concepts are important for us as we move forward in our careers and train, and they're important for our patients. And operationally, which, anyway, is there a laser pointer on this, or am I? Everything will shut down. I use the mouse. Okay, great, thanks. So, you know, operationally, what does resilience really mean? If you're kind of chugging along and something bad happens to you and your quality of life goes down, if you chugged along right there, you'd be surviving. So you're not really passing away, or you're not doing great. If you bounce back to where you came from, it would be resilience and so. But then, if you do even better, you would be thriving. So just kind of keep those concepts in mind. So I'm going to talk a little bit about the story of my family. Jeff alluded to this a little, and I think over the last couple of years, I certainly have thought about their story and how that has helped instill hope and resilience in me as a person. And I want all of you to reflect on your own families and where you learn lessons of hope and resilience. Could be totally different than mine, but I think it's important. So both my parents grew up in small towns in Iran. They met each other in their early 20s. They each had 5 other siblings. My mom had 5 sisters. My dad had 5 brothers. And they married very young. And they decided to move to the capital of Tehran. Shortly thereafter, my dad got something in his head that he wanted to move to Italy to study architecture. He had read some things that, you know, Florence was the place to learn architecture. My mom actually had gotten into medical school in Iran at that time, which was really kind of a big deal in the early 50s. But they decided to focus on his career and move to Italy. And they had a lot of hope for that. You know, neither of them spoke Italian. Neither of them actually spoke English or any other language. But this is them in Bologna learning Italian before enrolling in university. And both of them enrolled in university in Italy. They were not well off, so they both had to take jobs, full-time jobs, to be able to support themselves. My dad worked as a draftsperson. My mom worked as a hairdresser and went to university, and they both graduated. And once they were done graduating, they returned back to Iran. And my dad had a very successful architecture practice in a developing country. It was a great place to be. Raised 2 daughters, and my brother was older and had stayed in Italy for schooling. Again, they went off the beaten path a little bit, I would say. So they put both their daughters in an American school. So remember, they had 10 siblings. No one else did such a crazy thing. There was no reason. They didn't speak English yet either. So for their daughters to go to an American school, but they had a lot of forethought about what their plans were. And their plans were they wanted their daughters to get an American education and come to the US and get an education here. And they just thought if they spoke native, English well at an American school, they would do really, really well. One little problem is that the Iranian Revolution happened. All the schools, the American schools, closed. So now they had 2 daughters who really actually weren't that great in reading and writing in Persian. And really, my parents felt strongly that we shouldn't stay in Iran because there would be potentially repercussions for our future. And so they were like, you're gonna leave the country. And so again, they had planned ahead of time. So they had planned that we would be speaking English, but they hadn't planned for this event, right? The plan was to go to college, not to be, 12 years old and 6 years old and not know where the next steps are. So actually, among this turmoil, they sent us to Italy to live with our 21-year-old brother. So the 2 of us went to live with him. And imagine he's a college student in Florence, living by himself. And all of a sudden, his 2 sisters and the dog, by the way, show up that he has to take care of. And all of you have siblings. I don't know how many of you have kids, but certainly it would freak me out to be sending my 12-year-old and 6-year-old to live with my 21-year-old in Evanston right now. But if it had to come up, I think that's the kind of choice that many of our families have made, and to have hope that things will work out. So there we went to Italy, and eventually, as a family, we all moved to the United States when I was 16. And that's where I went to college and medical school in New York City. And when I was thinking about what career I want to choose, there weren't a lot of women choosing surgery. And at Columbia at that time, there was exactly one woman surgeon. And she spent all the time that I had with her telling me how I shouldn't choose surgery. And there weren't a ton of role models, honestly, that I could look up to. And so I went to my dad and I said, well, you were passionate about your career and you took a lot of chances. What should I do? And he said, well, definitely you should choose surgery if that's what you're passionate about. So what if the trail has not been blazed or isn't super obvious? And that's what I did. And, that's where I am now with some great colleagues that I work with at Mass General. That's our endocrine surgery group. I love what I do. I really, really do. I wouldn't switch it for the world. I'm glad I listened to my dad and not to the one single surgeon who definitely was trying to tell me. And I love my career because it's very, very varied. Okay, so I do still operate and take care of patients. I do some teaching, I do some research, and I don't really do populational health. So I do 3 out of the 4 things that are on this slide and very much continue to enjoy it. I did want to talk a little bit about the career path because I think, especially if they're students or early career residents, it's nice to see kind of how things work. So, this is the path I took, right? I went to medical school, eventually I went to UCSF residency. And when I was a resident, I was able to get some training grants. So like many of you put up today, your funding grants. So those are small seed grants, $30,000, $50,000 that are starting your careers. And those are really, really important. Then when I took my first job with Jeff in 1998, I got some seed money for starting my lab. It was a small amount of money, but it was super instrumental. I then went on to get some foundation money. Notice the American Thyroid Association, American College of Surgeons. So all these are little grants that you can write. Some of them are only 50 or 60,000, some of them are 100,000, but that all little adds up. Eventually a K award, which is an NIH award for mentored research. which for me was really important. A little bit of pharma money along the way when things were dry. And then eventually in 2010, I was able to get sort of, I'd say, the gold standard kind of R01 money. And the reason I like to point that out is because it's kind of a long path. And this is where many of you are at. And this is the work that I did when I was a resident. So I published really, I think, just 2 papers. So you're all well ahead of me. I think someone said they had published 9 papers today. And I worked in Doug Hanahan's lab. He's the guy here, and with Judith Oakman. And they were sort of the fathers of angiogenesis. They had defined angiogenesis, but Doug is the first person who invented a genetically engineered mouse. So it's a great paper. Actually, he founded the very first genetically engineered mouse all by himself. It's a one-person publication in Nature. And it was this RipTag model, which was an insulinoma basically in the pancreas of mice. And my entire lab project was very simple, which was to define when in the islet tumors, they all have the same genetic abnormality, which is a T antigen is being expressed with the insulinoma, with the insulin promoter. But over time, some of the islets become angiogenic. And as they become angiogenic, the tumor becomes invasive. So really one of my projects was to take these animals, give them anti-angiogenic drugs during their lifetime and see if we could prevent tumor formation or shrink tumors. So not exactly rocket science, but it did get my interest in how we can use animals to study drugs, and then can we translate that to humans. So again, I just want to point out that, you know, when I became an attending in 1998 at age 32, it took me till age 44 to actually get my R01, okay? And at first you might look at it, because I know where's Luca, who already has an R01 being an attending. But actually, if you look for an MD, this is the average length today. It's 11 years. Actually, it was 11 years when I was an attending, but exactly these ages, I looked that up. Now it's slightly longer, or something like 11.9. So even though I seem like a failure in this slide, this is what you should expect, that it will take you, even in a really good environment where you did the right kind of research, you got those seed grants and everything. It's not going to happen overnight. And it's important if you go to try to find a job that you understand that. So some chairman somewhere doesn't tell you, I expect you to have an R01 by year 3, and you're not like, oh, okay, that'll happen, because that likely is not going to happen. And during this period, right, between 32 and 44, all kinds of things are happening in our lives. We're not just sitting in a vacuum, just writing grants all day. What were the things for me? Well, I was teaching residents how to do surgery. I was learning how to do new surgeries, right? New surgeries were coming up. I had mentees in the lab. This is Ben, who's an associate professor now at University of Rochester in Endocrine. I had 2 boys, so I had to raise them with my husband. I had a lot of fellows, you know, basically clinical fellows who were with us. We had medical students and trainees. This is Dr. Carrie Lubitz, who's now president of the Association of Academic Surgery this year. And also I had aging parents, right? The same parents who'd installed all that in me and helped me get here. They were aging and needed my care as a daughter as well. So lots and lots of things happening in life. Now, just to kind of bring it back to the research, because that's what this symposium is about. Once I got my R01, I had, you know, about $1.5 million that I could try to think, what am I going to do with that, right? Obviously, I'd written what I was going to do with it, but I think it's always, once you have the money, you really have to settle down and do the work. So for me, I went back to what I knew, right? I knew how to work with mice, and I knew how to translate clinical trials in mice. So I went to what I knew how to do. Now, the only thing I did was try to ask questions around that, right? Like, what genes might be important that I could put in the right mouse model? How can I use the mouse models to test clinical things? And then how can I improve patient outcomes, right? That's sort of the ultimate goal. And in my thinking about this, I saw this patient actually at the Diaz. She was actually in a LPN on the floor, and she presented with shortness of breath. She had a goiter a long time, and she had the sudden kind of growth of this outer portion of the goiter further out here that sort of grew fast. As soon as we got the CT, we knew she had massive lung mets here. And the diagnosis seemed to be some kind of bad thyroid cancer. Of course, I was young, only 4 years into being an attending. I thought this was resectable, which in retrospect was not the brightest idea, but I did resect it fully, obviously not her lung mets. And she died, this is exactly 1 month later. She died at home. So I actually helped her a little because she got home and she wasn't as short of breath, but really I didn't help the patient at all, right? But it got me thinking about this disease, which is anaplastic thyroid cancer, which is the transformation she had had in her goiter. So anaplastic thyroid cancer, median age is 60, just like our patient who was 61. It's a very rare cancer. There's about 800 to 1,000 cases a year. Most patients present like her with hoarseness, stridor, trouble breathing, trouble eating. And there's metastasis in at least 50% of the patients. And all patients, when they present, are stage 4. So think about that. Most cancers have stage 1, stage 2, stage 3. There's no such thing. There's only stage 4 in anaplastic thyroid cancer. And there's a very high risk of death. And average patients really live somewhere between 3 to 6 months. So that's the survival. The disease just really grows very, very rapidly. This is one patient just 2 months apart, essentially. So let's talk about the staging a little bit. So stage 4A is when the tumor is intrathyroidal and may or may not involve lymph nodes. So really, if you just get a 2 millimeter anaplastic thyroid cancer, it would be stage 4A. Those are basically incidental, like you happen to take the thyroid out and you happen to see that. You get stage 4B, where it's extrathyroidal, can't be surgically removed, may or may not involve lymph nodes. And then stage 4C is there's metastatic disease, which remember, more than 50% of patients. And here's the survivals, 9 months for even the 2 millimeter intrathyroidal one. The survival is often less than a year, 5 months and 3 months. So this disease caught my attention because most patients are very difficult to manage clinically. They have trouble swallowing, they have trouble hydrating, they have airway complications, they need a tracheostomy, which sort of doesn't really extend their life, and it really is not great for quality of life. Often the tumor will grow through the tracheostomy while you put it in place. It's also very difficult to diagnose pathologically. So altogether, a bad disease. And pre-2012, when we started looking at this disease, you really would think you would diagnose it best you could. You would do surgery if possible, almost never possible. You would then try standard chemotherapy regimens with or without radiation, with little to no impact. And then you would sometimes try cytotoxic chemotherapy. So what were the barriers at the time that I got my $1.5 million? Well, the patient numbers were very small, so it wasn't an easy disease to study. Clinical trial designs, just by definition, didn't work for this disease. Most patients couldn't swallow medications. A lot of times they were older, they had comorbidities. They deteriorated so fast that by the time you tried to review their histology centrally, they would often then not be able to eat anything and they would just die. And because of that reason, no anaplastic thyroid cancer trial had enrolled fully before 2014. So no trial had ever been completed for patients with anaplastic thyroid cancer. Furthermore, it was like one of these diseases where everyone just gave up on it. And they were like, everyone's going to die. Why are we even studying this? Which was really a barrier to developing any kind of a team. And nobody really understood the disease on a molecular level either. So our lab, along with multiple other labs, started working on this problem. And step one was just understanding anaplastic thyroid cancer. So just to kind of look at things, thyroid cells are 2 different kinds of cells. We have follicular cells, which make thyroglobulin, and we have C cells, which make calcitonin. And when they become tumors, they become medullary. We're not going to really talk about that pathway, but the most common thyroid cancers come from the follicular cell. Usually they're papillary thyroid cancer, follicular thyroid cancer, or Hürthle cell cancer. when things go further south and they become more dedifferentiated, they can become poorly differentiated or anaplastic. But they're sort of deriving from that follicular cell. So some of the mutation alterations in the anaplastic have been finally understood, mostly through efforts of big groups, which have spent money, millions of dollars, looking at the samples. And it turns out that P53, TERT, RAS, and BRAF are the most important players. So there's not one mutation that's driving this disease, it's multiple mutations, but at least we understand the common mutations now that drive this disease. So notice that 25% of them have these BRAF mutations. So I took basically gene discovery, which would be discovering these genes, not by me, but looking at what role does BRAF play, develop models that included BRAF in anaplastic thyroid cancer, and then test basically drugs that target the BRAF. So very simplistic. I wasn't the only one working on this. We were a small group of people that worked on this from different angles. So Jim Fagan is in Memorial. He developed a transgenic animal model with BRAF initially in the lung, and then eventually inducible models of ATC, so expressing BRAF at the transgenic level, eventually inducible, and then conditional targeting with Dr. McMahon at UCSF and Dr. McFadden, who was with us at MGH, but since has moved to Texas. So the reason I'm emphasizing this, because a lot of these models, these transgenic models, so these 3 or 4, you would express BRAF, you would turn it on. Eventually you got ATC, but it could be 253 days. And when it happened on a 1 day. So if you're a postdoc and you happen to be ultrasounding the mouse every day, if you were gone for 1 day, it happened always on the 1 day you took off, somewhere. And so it wasn't really a very useful model for clinical trials. McFadden's actually was a little better because he took BRAF, he crossed it with either P10 mutant mice or P53 mutant mice, and that was a little faster, but still what we call is sporadic, kind of random, which is actually what happens in patients. It's just not very conducive to studying things. So I took a different approach, what I call a kind of a dumbed down approach, which was more taking human thyroid cancer cells, which were BRAF mutant, and injecting them into the thyroid of the mice who were immune compromised mice, so they could tolerate the thyroid cancer cells. And then basically let them grow up over 5 weeks. They were labeled, so you could see the tumor growing. Here's the tumor, here's the trachea. Trachea is getting invaded by the tumor. This is the normal thyroid on the opposite side. And here are the lungs. So massive metastatic burden within 5 weeks to the lungs. And this was reproducible over and over and over again. So very boring. So if you followed the mouse for 5 weeks, you always got more or less the same picture. The tumor in the thyroid grew slowly, but eventually engulfed the whole trachea, very similar to humans. And the lungs by week 3 started getting lung mets, and by week 5, the animal was always dead. So now we had kind of an idiotic, but sort of simple system to study drugs. So we did, I won't bore you through all of that, but we did all the preclinical studies for BRAF inhibitors and MEK inhibitors in this very simplistic model, and basically showed that if you use your BRAF inhibitor or a MEK inhibitor, you are likely to change this disease. And so these all went into clinical trials, none of which I did because I am not a medical oncologist, but a bunch of them got FDA approved for this disease. Okay, so sort of getting to the patient was really important here, and these happened pretty fast. So we went from a disease where if you tried surgery, maybe you tried radiation, maybe you tried cytotoxic, to a sort of a molecularly driven therapy for patients. And that molecular driven therapy made a lot more sense. And so I'll show you some examples in a minute. Step number 2, remember we talked about everyone's given up. There's no team to take care of the patient. Everyone says, why are we even trying? So developing a multidisciplinary team. So of course we have a big team at MGH. We have endocrine surgery. We have people working in the lab. We have resident and fellows. We have endocrinologists, laryngologists, radiologists, cytopathologists, and oncologists all working on the same disease to help the patient. Other places, same exact idea. So this is the MD Anderson anaplastic dream team. So a couple of places in the country have set up these sort of very concentrated, and I think their team is actually called the FAST team, in order emphasizing how you have to get the patient to them quite fast. And that's really important because you have to start the pathologic review rapidly. You have to evaluate the airways rapidly, determine if it's resectable or not, because within 2 weeks, it's not going to be if it was. And then are there distant nets or not? And PET-CT is very helpful for that. So another really important thing that we had to do was think about mutation testing. Because if we're going to give BRAF inhibitors, it's only going to work for the people, the 25% or 30% who are BRAF mutated. So BRAF is one of the more common actionable mutations in anaplastic thyroid cancer. How do we test for it? Because it's so central to our paradigm, right? Because after we ask the question, is the airway stable? We're asking the question, are there distant nets? Is there going to be resectability? Everything boils down to what is the BRAF status of the patient. And remember that getting the tissue is difficult, right? By the time you write the person up in Maine, for us, all our patients come from Maine for some reason that I don't totally entirely understand. And you ask for the thing, and even if they FedEx it, by the time you look at everything and you get the results, it's more than 21 days. So remember, life expectancy is 2 months, so 21 days is almost an entire half of their life expectancy. So 2 things have been developed to try to do this faster. One is there's actually a mutant BRAF antibody, so you can actually just get the tissue and do a quick antibody staining, and you can get the answer that way. Or you can do cell-free DNA, like liquid biopsies, like we talked about today a little bit earlier. And with the liquid biopsy, where you look at the cell-free DNA in the blood of the patient, you can reduce that to somewhere between 7 to 10 days. So both of those are really good options. And there's been decent studies where there's about 90% concordance between the tissue and the blood. So it can expedite you getting the patient in. And then the 4th step is really getting the oncologist interested in this disease. So it turns out that oncologists generally don't treat thyroid cancer. It's mostly endocrinologists. Radioactive iodine is given by endocrinologists. Most common treatments for thyroid cancer aren't given by endocrinologists. So oncologists really weren't interested in this disease. So we had to get our own oncologists interested in treating thyroid cancer and starting clinical trials, because no one else really could do the clinical trials. So here's an example of how things are drugs that actually in the last, even the next like 2 or 3 years became available. So you can see you have BRAF inhibitors, you have MEK inhibitors as the central elements, but then you also have lenvatinib, so a more multi-kinase drug inhibitor, which probably has significant angiogenesis effects, and then multi-kinase inhibitors as well on this front. So in a nutshell, these drugs got given to patients in parts of clinical trials and partly off clinical trials because there was no other treatment for these patients. So here's a good example of a patient who has, by PET-CT, a huge neck mass, very invasive, invading the trachea, invading the esophagus. The vascular structures are all not able to be seen. The patient gets a BRAF inhibitor, and you see massive reduction of the tumor. And here's, an example. You get a core biopsy of this massive neck mass, and this gentleman here, it's all his neck, basically. Within 7 days, you can get your sequencing done on the blood biopsy. You start BRAF and MEK inhibitor therapy, and remarkably, 7 days later, he has much reduced dysphagia. The mass has halved in size. So they can be pretty remarkable and powerful drugs. And here's an example where the drugs can be given. So this is BRAF inhibitor plus MEK inhibitor. They're both in the same pathway. It turns out now we know they're much better when given together. And you can get pretty massive tumors shrinking away within 20 days. So here's a huge tumor, and then now look what's left of it after 21 days on the PET-CT. And these patients are now actually all part of a clinical trial to see if you can shrink the tumor with the proper BRAF and MEK inhibitor, and then you can do surgery on them potentially if need be. So neoadjuvant therapy, which was something that really was never done before. And for these patients, 12-month survival increased to 83%. if they responded to the drug, and then some could have gone on to surgery. So again, finally, we got clinical trials of anaplastic thyroid cancer patients that got completed. You actually got, for example, in this case, you had 16 BRAF mutated ATC patients. The overall survival was 80% at 1 year if they were put on BRAF and MEK inhibitor therapy. And this drug was approved. The combination drug was approved in 2018. So this of course, not everything's perfect, right? You give BRAF inhibitor, you get MEK inhibitor, and you learn a lot from your patients. This is a patient of mine who I operated on, I think at least 4 times, and his cancer kept coming back. Here it is coming back around his carotid artery and eroding through the skin. The patients develop resistance to therapy, so you'll give this person a BRAF inhibitor, and it'll be like, okay, I'm grown right through that. Some patients actually developed cutaneous squamous cell carcinomas or in other places and died. This is actually a patient that happened to of mine, who I thought I was doing them a great favor, gave them this BRAF and MEK inhibitor therapy. They actually got a squamous carcinoma growing in the lung and died from that. We also didn't know what effects BRAF inhibitors or MEK inhibitors are having on the immune system of the patient, because studies were coming out with melanoma showing that BRAF inhibitors actually have effects on the immune system. And of course, immune therapy was starting to come out around this time. So what did we do? We went back in the lab and said, how can we develop better models that are immune competent so we can then study the immune system's response to BRAF inhibitors, and we can study whether we can give immune checkpoint inhibitors, right, the hot drug. So I won't bore you to death, but to say that, remember the McFadden model? We talked about the mice that had the BRAF mutation plus the P53 or the P10 mutation. And we took those mice, because those were basically immune competent mice and transgenic mice. We took their tumors, we grew cell lines out of them, and then we injected those cell lines, because remember, they might grow the tumor in day 253 and we couldn't really study them. But we put them in the mouse thyroid and pretty much recapitulated the other model I showed you. So we got it to grow in the mouse thyroid. It actually is a super aggressive, once P53 is in there, it grows more like 2 weeks. So you get aggressive tumors in 2 weeks. And now we were growing these tumors in an immune competent environment. So we could study what's happening to the macrophages, what's happening to the regulatory T cells. Can we give immune checkpoint inhibitors? And what we found is that if you gave nothing, the mice would die by 2 weeks. If you gave BRAF inhibitor or MEK inhibitor, they would live longer. And if you combined immunotherapy with BRAF inhibitor, they would live the longest. And immunotherapy by itself, no good. It was as if you hadn't given anything, it turns out, in this disease. Another drug, lenvatinib, same findings. So you could combine lenvatinib plus an immunotherapy, and you got the best survival result. So again, we went back to what we knew best, which was how to use animal models, thought about how can we get an immune competent mouse model, and then work towards answering our questions. And again, now what you can see is that addition of immune therapy to targeted therapy in anaplastic thyroid cancer has become the standard of care. We've gone through clinical trials, and again, going back to that patient, so they did great by day 14, then day 37, their disease started progressing again. Then they got Pembro, so an immune checkpoint inhibitor, and they were still alive and doing well by day 90, which really would not have happened without that. And the patient is still alive 2.5 years later. So we're testing these drugs in combination in mice, much easier to do than try to test them in humans, and then pumping out the data to the medical oncologists who can run the clinical trials. I do think it's really important for surgeons to, though, stay involved in the care, not be like, okay, now I've done my job like medical oncology, you do the work now, like I'm going to sign off mentally. And these are good examples of patients. So this is a patient who presented with a massive anaplastic thyroid cancer with infiltration into the anterior neck muscles. There was already disease in the trachea. There was massive disease throughout the body, and especially in the upper mediastinum and the lungs. We gave her BRAF inhibitor and MEK inhibitor. Actually, it could have been lymphadenum. I think in her case it was lymphadenum. And immunotherapy in combination. The tumor melted away, in some places not in a good way. This is her developing her own tracheostomy. Essentially, the tumor melted away anteriorly, and she developed a tracheostomy. She is alive though. She's alive today still, because these combination of drugs was powerful enough to shrink the tumor. And then she got radiation, and she is still alive 5 years later. So again, just like multimodal therapy, hitting it with everything up front. When you know the molecular makeup, it's very helpful. That's just a picture, incidentally, of her where the fistula was. This is right, the hole right there, basically, of her tumor. So now, things have gotten complicated, but that's how you see the world develop. So patients come in with anaplastic thyroid cancer. They get mutation testing. Do they have a BRAF mutation? If the answer is yes, then they go basically to a combination of BRAF inhibitor, MEK inhibitor, and a immunotherapy. If they have a RAS mutation, they just get the BRAF inhibitor and I'm sorry, they get the MEK inhibitor plus immunotherapy. If they have none of the above, we try angiogenesis inhibitors. It turns out now we have most of the data from this trial, and this arm doesn't work at all. It turns out it confers no benefit to survival. But the point is, we started somewhere from having little knowledge about this disease, little knowledge about its molecular thing, and we worked together, all of us, at slow little bits at different places, Memorial, MD Anderson, our lab, to plug away at the parts that we could. And really now, I'd say in the last decade, the approach to anaplastic thyroid cancer has completely changed. We have 3 trials that have completed enrollment, and we have FDA-approved drugs. There are now 3 more open current trials, which will likely get completed. Overall survival, of course, the ultimate important thing, has improved. And we've turned anaplastic thyroid cancer into a survivable illness. It's not great still. We have a lot of work to do, but we're much, much better placed than we were. So big thank you to everyone that's worked on this group. I'll give a little bit of time. So I'm just going to tell the story of the International Thyroid Oncology Group, because I think this is an important story for us to advocate for our patients. It turns out, I don't know how many of you know, there are these cooperative groups, right? The NIH used to run all the clinical trials, but decades ago they said, no, we're going to give it to the money to the cooperative groups, and then the cooperative groups get to decide how the money should be spent on clinical trials. So there's a cooperative group that has breast cancer and colon cancer, another one that has sarcoma. So all the cancers were assigned. Well, guess which cancer was completely forgotten? Was not assigned to any cooperative group. It was thyroid cancer. So fast forward, around this time, maybe 10 or 15 years ago, we actually went to the NIH and said, guess what? Like, they're actually thyroid cancer. We can't run a clinical trial because we're not assigned to any cooperative group. And they said, really? Like, how did that happen? And so they actually convened a group at the NIH, and they said, let's get together and put our heads together. And then they said, well, you can ask for money from any of the groups, and maybe they'll be able to help you. But it turns out we asked many, many groups, and they all basically said, thyroid cancer. Like, everyone lives with thyroid cancer. Survival is 99%. I'm working on sarcoma, much higher mortality. I'm working on whatever. We weren't even a blip on their radar. So we had to make our own oncology group, actually, the International Thyroid Oncology Group. It's basically founded by a medical oncologist, an endocrinologist, and the family of a patient who died from thyroid cancer. When they understood this, we've raised close to probably $3.5 to $4 million in the last 6 or 7 years. It's not a lot of money on the cancer scale, but actually it's helped support a lot of the research that I'm talking about. Both in MD Anderson actually has supported my lab, and is now supporting not just anaplastic thyroid cancer research, medullary and Hurtful cell. But it's just kind of sad to think that the whole cancer could completely get forgotten by the NIH. But even when you pointed out, I don't know that there was an easy solution, unfortunately. I think we talked a little bit about my mentors. So Orlo Clark was an endocrine surgeon at UCSF, and Doug and Judith and I talked about. Keith Will, my current chairman, has been hugely supportive. All the people I've done research with and have mentored me in the past, 25 years. I've learned a lot from the residents and fellows that I've worked with. It's really, I'd say, a two-way mentorship. A lot of things that I learned from them all the time. This is my family. My husband is a urologist and also does a ton of research. These are our two boys. That's the day that I became professor. And I just want to point out this photo of my mom, who was very excited about coming to my professorship ceremony. And this is her looking at the certificate Harvard gives you for becoming a professor. It's the most excited I've ever seen her about something, and I'm sure it's related to the fact that she could have gone to medical school but didn't go. Very emotional day. I would say it was also the day my son got into Northwestern, so double whammy. So I think that's it. I'll take any questions. Thank you to the audience on Zoom who's really sat through the whole day and asked great questions and been super engaged. I'm sorry I didn't get to see you in person.
Let's see if we get questions in the chat.
In the chat or the.
Yeah, raise your hands first, Dr. Quicken, and then Dr. Masala.
Thank you very much. Great lecture. Sorry, I joined a little late, but I was on Zoom on the way over here. It's quite a walk from the OR. It takes like 20 minutes, even with my long legs. So my question is, and you may have mentioned it, and I'm not sure, but when you talked about how your mouse model responded to immunotherapy, like in combination with BRAF or MEK inhibitors, did you study why that is? Meaning, do they have higher PD-L1 expression? Are there any markers to tell you that they are going to higher like tumor burden, like mutational, like tumor burden, or anything from your mouse model that you could apply to humans to try to understand who would respond and who wouldn't to this therapy?
Not in the way you're thinking, I think, but we did study a lot of sort of how, what is the effect of the BRAF inhibitor and the MEK inhibitor, or the mutant BRAF on the immune cells.
Okay.
It turns out there's a ton of effects on sort of which immune cells come into the tumor. And it turns out the immune, milieu of anaplastic thyroid cancer is amazingly fascinating. So in humans, 50% of the tumor volume is actually macrophages. And so it's fascinating to see how could you convert those macrophages to attack the tumor. There's many different elements, but the short answer to your question, which is like, could we do PD-L1 staining or something to say that these are the responders, these are not the responders? We didn't really find anything.
But because your PD-L1 arm only didn't really respond to therapy in your mouse model, it suggested, like you said, that probably the MEK inhibitors or the BRAF inhibitor turned maybe like a cool environment into a hot environment, basically.
We think so, because
that's
that's
fascinating.
turns out it's true in humans too.
Yeah,
So
that's
in humans
fascinating.
do just single agent immunotherapy
Doesn't work.
just doesn't work for us. There's like a patient or two that maybe it worked for a little while in the basket trials, but generally they don't work.
That's fascinating. Thank you.
Dr. Parengi, thank you very much. Wonderful talk. I guess what I was really struck by was how fast things moved from a basic model in a mouse, then to clinical trials, then seeing problems in the clinical trials, and then moving back to a mouse model. So what advice would you give to a younger surgeon scientist? I personally struggle with this a lot, in that saying, okay, is this model good enough that I can actually take this into a patient, right? And how have you thought about that? And the patient you mentioned that you said, well, now I gave them squamous cell in the lung and they died. Thank you.
I think this is what's great about surgeons, right? Because you're living the experience, you're seeing the patients, you're like seeing, oh my God, that tumor's invading the trachea. Like I have to come up with a solution. So I think the fact that you're a surgeon really adds to the team, and I think you just have to stay engaged because the natural tendency for at least in where I see things, I could be wrong, is a lot of times your collaborators view you as a technician. Yeah, okay, can you get me the tissue and then just shut up, basically? And that's really the wrong attitude. Because if that's all they want you for, they can pay a tissue bank coordinator to show up and get them the tissue, right? What you add as a value is the real life of what you're seeing as the problems. And people like Judah Folkman, who was a surgeon, always talked about that. That really, as a surgeon, you need to see your value. I think as far as the fast moving part, I'll say I think some of it is just luck, right? Like if you have a disease for which there's no treatments, then the treatments you come up with. But some of it was calculated, right? Like we were reading the literature and thinking, oh wow, look at what this mutation means in melanoma. And we were like minute to minute reading every article that came out. So then when it was, when we saw that BRAF was a hit and not in the anaplastic, we're like, okay, we're gonna jump on that bandwagon. And again, some people will poo-poo that. Okay, well, you're just copycatting from melanoma. Okay, yeah, but it helped these patients and we got what we needed, which was therapies for the patients, because the drug companies weren't going to give it to us just to use it without doing the work. The other thing is I found that working with companies was very helpful, right? So these BRAF inhibitors had come out. They were made by a company called Plexicon. They were looking for other, cancers to treat other than melanoma. And so when we went to them and we said, we have to come out of anaplastic thyroid cancer, can you give us the drug? They were like, in a minute. And they really cooperated with us. They gave us drug. We said, it's hard to give it to the mice with the IP injections. They said, okay, well, we'll make chow with the drug in it and give it to you. So they really cooperated with us and we were very close with them in relation. Now, some of those relations turned the other way though, right? So we tried to beg for them to do clinical trials in thyroid cancer, to pay for the money to run basically investigator initiated clinical trials. And a lot of them were like, yeah, thyroid cancer, 1,000 patients, just not enough. Like, it's not, we're going to go for colorectal cancer instead. Well, it turned out actually BRAF inhibitors weren't effective in colorectal cancer. So they spent a lot of money and it turned out not to be an effective clinical trial. But they were kind of negative on it. But that's why with the help of the International Thyroid Oncology Group, we were able to get other drug companies that were richer. The other problem is the drug companies often, if you have combo drugs, no good. If one company makes all three drugs, great. But if you have to go to 3 different companies, they don't want to cooperate with each other.
Dr. Alberti?
Oh, yeah. Thank you so much, Dr. Frankie. That was truly inspiring and a wonderful talk. And I'm just struck by your story. It's so fascinating. And you talk about this engagement with the patient and engagement with teams, but it strikes me that not only are you engaged with the patient and his or her disease and the multidisciplinary team, but also with their genetics and with their biochemistry and with industry and with the NIH. And, you started talking about hope and resilience, and it's really striking about how it takes up to age 44, 45, 46 to get your first R01. But that's really just not the whole story. The story is at the end of this, forget about grant success and climbing up the academic ladder. You're testament to how you can take care of a patient with this, even the word anaplastic kind of creeps me out because it's like, this thing has lost complete control. It's got no features. It just has no conscience. It's like a sociopath going crazy in the body, and you look at this and you don't look at it like, how am I going to fix this? How am I going to remove it? How am I going to diagnose it? You think about how you're going to control it through the entire stages of all your training and your engagement from the gene out, and that is hope and that is resilience, really, hanging in there this long.
Thank you. That's really nice of you to say, John. And I think it's important for the residents really to hear that the skills you're developing now, like I did during my residency, right? I've learned how to work with animals. I learned how to work with transgenic animals. I learned how to culture cells. I learned how to use them for clinical trials. I met with important people that got me thinking about these things. Those are all things that will, boy, they will come in so handy for your patients and the way you think in the future. And John is right. It's not one thing, right? It's not one brand or one little thing. It's just the whole combination of plugging away at it, enjoying it, being passionate about it. I mean, Jeff is a role model because when I met him, he was passionate about research, and he showed me that, you know, he didn't say, oh, no, surgeons shouldn't do research. He was like, come into my department and start doing research. So I think that's, you know, as all of you set up your own careers, you'll slowly make your own story. This is just one story. You know, John's story is amazing. Jeff's story is amazing. Everyone has their own stories, but hopefully you can develop your own story. And as you do, don't be discouraged, because, you know, the skills you have are tremendous. They really are tremendous. Everyone values them. It's just that sometimes people don't talk about that. And then that can get depressing. Like, oh, I'm just a technician. I just operate. That's all I'm good for. You gotta fight that all the time.
Quick question. Again, thank you for this excellent talk. So I think Dr. Madriaga last night mentioned to you a patient that we presented at STS who had anaplastic thyroid cancer, got dabrafenib and trametinib, did fabulously with the neoadjuvant therapy and ended up getting a tracheal resection and reconstruction. They're now on extended maintenance dabrafenib and trametinib. And as you sort of touched on, that's not necessarily a completely benign medication to be on for the rest of their life. At what point with this disease do we start trying to figure out when we withdraw that treatment? And how do you begin to figure out that we've made that transition?
Yeah, I think that's a really good question. Certainly we have had patients stop the therapy and do really well. Mostly they stop it because they can't tolerate it anymore, right? Something bad happens, like develops severe diarrhea or congestive heart failure or some major problem. So I think it's just, you know, how brave are you to try it on the patient's behalf? I think it's very feasible to stop it if you think the patient has no more residual disease. Often we do also give radiation on these patients afterwards, so that sort of adds an added reassurance, I think.
Dr. Pring, I want to thank you for an unbelievably inspiring lecture and all your contributions the whole day long. This was a marathon. You survived it from 6:15 in the morning until your keynote address. And I think everybody who's interacted with you and all of us today really benefited from this incredible day with you. And your stories and your successes are an inspiration to all of us. Thank you so much for being our 29th Huggins keynote lecturer. Things will follow, which will get to you, and we are really thrilled with the day. So that concludes the day, and we'll get you out to see your son. Yeah.
Just thank you, everybody, for staying all the way to the end. I want to thank Paige Kirkpatrick and Janine Gohar for all their hard work in organizing this and making this a really wonderful day. And I wish you all well and hope to see you again next year. And thank you, Dr. Parengi.
So Jane's gonna get you out.
Okay.
All right, you're done. Such a pleasure.